Chairman, I've just been notified that we are now live.
Thank you. Good morning. Welcome to this virtual meeting of Cornwall Council's Health and Adult Social Care Overview and Scrutiny Committee, the last one for this 4-year cycle. Before consideration of today's business, I will outline the protocols for the meeting. Today's meeting will be live streamed to the public via Microsoft Teams and is also being recorded. When a member is speaking, they may choose to use their video. If the council's live stream fails during the meeting and we cannot share the proceedings, I will adjourn the meeting so the access can be restored. If the issue cannot be restored, I will halt the meeting and the remaining business will be concluded at a future date. If a member experiences technical issues, I will adjourn for a short period to try and re-establish their connection. Members wishing to speak or ask questions should indicate by typing X in the chat box. As I call a member to speak, I will remind you to switch on your microphone. If for some reason you cannot be heard, the democratic officer will advise you. Votes will be taken using a roll call procedure. The democratic officer will read out the recommendation and the name of the proposer and seconder, and will call each member, committee member's name in turn. You should confirm your name and advise whether you vote in favour or against the recommendation, or whether you wish to abstain from the vote. The democratic officer will then count the votes and advise the result accordingly. Where members have declared a non-registrable interest or disclosable pecuniary interest, or an interest by the virtue of a trade union membership in the matter, that they must leave the virtual meeting. The departure will be confirmed and they will be invited to rejoin the meeting at the appropriate time. During the meeting, I intend to have a minimum of 2 short breaks. If the meeting runs beyond 2 p.m, there will be a short break in order for the live stream to be public, to the public be altered. Before we start today's business, I will ask the Democratic and Governance Officer to confirm the members and officers in attendance. Over to you, Miss Martin.
Good morning, members. I'm going to read each of your names in turn. If you could please confirm your name and your electoral division for me. So, Councillor Almond-Toms.
Councillor Almond-Toms, Lou Easton, St Martin's.
Councillor Colin Martin.
Hi, Councillor Colin Martin, Councillor for Lostwithiel, Vice Chair of the committee.
Thank you. Councillor Bert Biscoe.
I'm Bert Biscoe. I'm a member for Boscawen and Truro.
Councillor Nikki Chopak.
Councillor Nikki Chopak, divisional member for Poundstock.
Councillor Barbara Ellenbrook. Councillor Ellenbrook, can you hear me?
Were you calling me? It's Barbara.
It was indeed, Councillor Ellenbrook. Can you hear me? Could you confirm your electoral division for us?
Yes, I apologise. The postman's just been with my papers. Sorry, my name is Barbara Ellenbrook and I'm councillor for Redruth Central.
Thank you. Councillor Jackie Gammon.
Good morning, Councillor Gammon, Bodmin St Mary's Division.
Thank you. Councillor Loveday Jenkins.
Morning, Councillor Loveday Jenkins, Councillor for Crowan and Wendron Division.
Councillor Jane Kirkham.
Good morning, Councillor Jane Kirkham, Falmouth Smithick.
Councillor Lennox Boyd.
Good morning, Councillor Sheila Lennox Boyd, representing Saltash North.
Councillor Sue Nicholas.
Good morning, Councillor Sue Nicholas, representing Maritime and Perraneth Division.
Thank you. Councillor David Parsons.
Good morning, David Parsons from Bude.
Thank you. Councillor John Pollard.
Good morning, John Pollard, Hale North.
Councillor John Thomas. Councillor Thomas. I can't see him on the call at the moment, so we'll see if he's got any technical issues and come back to him. Councillor Andy Ver.
Yes, good morning, Andy Ver, Cornwall Councillor for Foy, Tardreth and Gallant. Please need to excuse me at 11:30 to attend an urgent casework meeting with Ocean Housing, and I shall return afterwards. Thank you.
Thank you, Councillor Ver. Councillor Peter Williams. Okay, I can't see Councillor Williams on the call, so we'll come back to him. John McClevey, our Co-op Chief from Health Watch, are you able to confirm you're here?
Good morning, yes, John McClevey from Health Watch Call.
Fantastic, thank you. Our portfolio holders, Councillor Rob Rotchell.
Yeah, good morning, Councillor Rob Rotchell, portfolio holder for adults.
And Councillor Sally Hawkins.
Good morning, Sally Hawkins, Councillor for Children, Public Health and Wellbeing.
Thank you. For members of the public's information, we will have a number of officers joining us today. I'll just provide their names and their role for the meeting. They'll not be here all at the same time. They'll be here to present certain items. So we will have Helen Charlesworth-May, who's the Strategic Director for Adult Care and the Accountable Officer for NHS Kernow. Natalie Jones, who's the Chief Nursing Officer at NHS Kernow. Andrew Abbott, who's the Director of Primary Care at NHS Kernow. Fiona Field, who's the Independent Chairman of Safeguarding Adults Board. Martin Bassett, who's the Safeguarding Adult Reviews and Development Coordinator. Suzanne Wixty and Keith Cheeseman, who are both Service Directors in Adult Social Care. And Carolyn Andrews, who is the System Transformation Director for the ICS. Thank you, Chairman.
Thank you, Deanne. Go on straight on to item 1, policies for absent. Are there any, Ms. Martin?
We haven't had any submissions of apologies. I will try to see if the 2 members that aren't present at the moment have any technical issues.
Okay, thank you. Declarations of interest. Any member wish to declare an interest on any item that's on the agenda? No, I think go on to the next item, item 3, which is the minutes of the meeting held on the 20th of January 2021. I'll read out the numbers from 1 to 14. Please shout out if you want to respond. Page 1, page 2, page 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 and 14. I'll propose and the Vice Chairman, Councillor Martin, will second.
Yeah, I'll second those.
Yeah. Are there any questions on the minutes? No. Okay, thank you. We'll go to the vote, Ms. Martin. One moment. Councillor Kirkham, you've just put your hand up.
I was voting prematurely, Chair. Sorry.
Thank you for your keenness. Thank you. To the vote, please, Madam Clerk.
Thank you, Chairman. Councillors, I'll read out your names in turn. If you can tell me if you're voting in favour, against or abstaining against the minute sign-off. So I'll start with Councillor Biscoe.
For.
Councillor Chopak.
For.
Councillor Ellenbrook.
For.
Councillor Gammon.
For.
Councillor Jenkins.
For.
Kirkham.
For.
Lennox Boyd.
For.
Councillor Martin.
For.
Councillor Nicholas.
For.
Councillor Parsons.
For.
Pollard.
For.
Councillor Thomas, have you managed to join the meeting? Okay. Councillor Toms?
For.
Councillor Ver?
For.
Councillor Williams? Okay. We are looking into if there is any technical issues with Councillor Thomas or Councillor Williams. With that in mind, we've got 13 in favour.
Okay. Thank you, Leanne. We now come to public questions. I'll read the public question, and Councillor Martin, the Vice Chairman, will read the answer. We have the first question from John Forsyth of Penzance, and thank you, Mr. Forsyth, for your question. What steps are Cornwall Council taking to work in partnership with the KCCG to plan and commission sufficient D2A provision, especially for the people on pathway 2, and ascertain the number of destinations and of patients discharged from Trelisk other than to their own homes? Councillor Martin.
Thank you, Chair. So in order to respond to the question and provide information for the committee, the Chairman asked officers for an answer. The response was prepared by Jonathan Price, the Joint Director of Adult Care and Health, Cornwall Council and NHS Kerno, and by Karen Kay, the System Director of Urgent and Emergency Care for Cornwall and the Isles of Scilly. The response they provided says, Cornwall Council and KCCG are working together to commission and ensure appropriate utilisation of the discharge to assess D2A provision for our population, both in the short term whilst we're in the pandemic and to meet the longer term care needs of our population. Trelisk are working with both NHS and social care commissioners and our colleagues in CFT as community services provider and the voluntary and community sector, and together we're adapting commissioning plans to best meet the emerging need profile of patients being discharged on each pathway. Work is well underway in modelling the changes we need to make to achieve the expectations set out in the National Hospital Discharge Policy. Our primary focus is to ensure that as many people as possible can return to their own homes for assessment with appropriate support to live as independently as possible. We've commissioned additional capacity in our reablement services on top of the numerous short-term care home placements we commissioned through our joint team. We have jointly commissioned capacity in 3 care homes specifically for a discharge to assess pathway 2, one in Callington, one in Penzance and one in Perranporth, with therapy capacity and GP capacity in place to support those homes. That's the end of the answer from the officers. I must say I'm slightly confused by the wording in the last sentence. It's not clear to me whether they mean jointly commissioned capacity in 3 care homes is in the past tense or the future tense. Have they commissioned something that's already up and running, or whether they've commissioned something that is coming in future? But unfortunately, I don't think we've got the officers there to give that clarification for us. Chair, I think you were muted by someone during that response because of the echo.
Okay, I'm sorry about that. Thank you, Colin. The second question is from Tim Stiles. Women in Cornwall face significant physical and mental health challenges as a consequence of the menopause. The nearest NHS menopausal clinics are situated in Taunton and Bristol. Will the committee write to NHS Kerno to ascertain if they would consider commissioning a menopause clinic? Councillor Martin.
Thank you. So the chairman requested an answer from NHS Kerno for the question that was posed, and the response from the Director for Planned Care and Integrated Care was as follows. A commission service is in place within primary care. However, for more specialised treatment, the regional clinics are based in Taunton and Bristol. This approach was agreed as part of a review undertaken in August 2016 based on referral numbers.
Okay, thank you. Welcome, Councillor Peter Williams. I see you've just joined the meeting. We come on to the next agenda item, which is agenda item 5, the Chairman's opening remarks. I think we're the second committee to do this. It's something new. I didn't really know what to write, so I sat down and what came into my head I put onto paper, and I hope you appreciate this. Good morning, everybody. I'm delighted to see you all today on the last meeting of this committee in the current council. Who would have thought back in 2017 that we would not be in the same room celebrating the work of this committee over the past 4 years? Firstly, I must pay tribute to the members that have served on this committee over this time, and the list below are put in this report to record my thanks to them all. Councillor Candy Atherton, Bert Biscoe, Nicky Chopak, Tim Dwelly, Barbara Allenbrook, Dominic Fairman, Jackie Gammon, Pauline Giles, Helen Hawkin, Loveday Jenkins, Jane Kirkham, Karen McHugh, Sheila Lennox Boyd, Colin Martin, Sue Nicholas, David Parsons, John Pollard, Andy Ver and Peter Williams. My thanks to Colin Martin for his vice chairmanship. From an ex-MP to leader of the council, to doctors, to nurses, to teachers and many other professions, even an ex-fisherman. The mix and blend that could only happen on a council's committee. But one thing shared by all those that have served on this committee has been the passion for health and social care for the people of Cornwall. Add to this the senior officers and leaders of the health and social care system in Cornwall and those in Devon who support the people of Cornwall, who work together hard over the period, who worked harder over the period than ever before. I'm sorry about that. With CQC reports adding the pressure, at times overwhelming numbers of patients coming through the door. They have fought back with hard work, determination, integration of services to solve these pressures. I remember Jackie Pendleton saying to the committee, we might not agree, but we can set aside our differences to make the system work. This partnership attitude has become more important over the last 12 months with the added pressure of the COVID-19 pandemic, and can be shown by the mental health strategy, which one officer said this would never have been achieved. Would never have been achieved. Sorry, I missed the line out there. This partnership attitude has become more important over the last 12 months of the added pressure of COVID-19 and can be shown by the mental health strategy, which one officer said would have never have been achieved. It would have taken 4 years to get that strategy through the normal processes, but they did that in 4 months. Public health has shown itself an extremely important part of the system, and briefings and information given to the committee has been excellent and informative. Thank you to Helen Charlesworth May, Kate Shields, Phil Comfort, Jackie Pendleton, your organisation, chairs, officers and staff for their work over the past 4 years. I look forward to seeing where the ICS takes Cornwall in the future and how adult social care white paper plays its part. What have we talked about? Well, we started with the accountable care system, then community hospitals, better care fund, urgent and emergency care system, Newton Europe, living wage, Stratton Hospital, CQC reports, ambulance waiting times, mental health, dental provision, access to general practice, the ICS, and many more. We added to the committee members with the addition of the Health Watch Cornwall joining the committee. In the last 4 years, the committee may not have always agreed, but we have always sought to do our best for the people of Cornwall, West, Mid and East. Yes, North and East Cornwall will not be forgotten, will they, Councillor Parsons? I know that several of those in the meeting will not be standing in the May elections. I thank them for the service, for their service to the people of Cornwall. But before you step away from this council, I will ask you to email Leanne with 3 most important issues for the next committee to look at. My last comment is to our organiser, fact finder, report chaser and note passer, Miss Leanne Martin, our Democratic and Governance Officer, who has over the last 4 years been my advisor, prompter and the best support a chairman could have. She has a wealth of experience gathered over many years with this committee and always knows where to find the information to assist the committee. Not everyone sees the immense amount of work she does behind the scenes to support this committee. I thank her from the bottom of my heart for all she has done. Just for Councillor Pollard, this report is not for noting, just to thank you and all the committee. Thank you and all the committee for your time, patience with me as chairman. I hope that's okay. I don't think there's any debate on that. It will be recorded. Your names will be recorded for the posterity, if you like, you know, so that if anybody looks back, they'll know who's on the committee. Thank you for that. We'll go straight on for the next item, which is item 6, the COVID vaccination programme verbal update.
Good morning, everyone. My name is Natalie Jones. For people who don't know me, I'm Chief Nursing Officer for the Clinical Commissioning Group. Just a brief verbal update this morning and some time for questions, if that's okay. Where we are at the moment, we have been vaccinating our most vulnerable people, and they're people over the age of 70 and those who are clinically extremely vulnerable. I'm very pleased to say that 94% of those cohorts, which we call cohorts 1 to 4, have had their first vaccine and are in the process of having their second vaccine. What we want to ensure is that all of the people in those age groups and clinically extremely vulnerable continue to have access to the vaccine, and we continue to ask our primary care networks to contact those individuals. And sometimes in the very early stages we may have had people who may not have wanted the vaccine, but because it's now becoming more of a normal thing, they may choose to have their vaccine now. So we keep going around to make sure that those people still have access to the vaccine. We've moved on to what we would call cohort 5, and they are people in the age group of 65 to 69, and moving on to those with long-term conditions, and then going down through the age categories. So we're doing them in order, but they overlap slightly, and the national letters, you'll notice, come slightly before the end of the cohort before. So the plan is to make sure that everybody who is over the age of 50 or with a long-term condition or clinically extremely vulnerable have their vaccine or are offered their vaccine before the middle of April. And then we will look to vaccinating those people under 50 and over 18. So that's the order in which we're looking at rolling out the vaccine. We also are looking to, we've established a group to look at those who are hard to reach, those people are homeless or travellers, etc., all those people that we need to pay particular attention to help them to access their vaccine. So that group has been established, And we are looking at messages for people, those people who are more elderly, respond to different sorts of messages to the younger population, and that will be picked up in that group as well. We're also expecting additional vaccines. We have the Pfizer vaccine at the moment and AstraZeneca, and more vaccines are coming online in the spring, so we should have more vaccine available to us to be able to go faster with the programme as well. I don't think I have anything else to say, but I'm very happy to take questions.
Councillor Toms, you're on mute.
It's Councillor Jenkins has got a question, I believe.
Yeah, it was about the clinically extremely vulnerable.
Yes.
And those with long-term conditions.
Yes.
Are they getting the letters at the same time as the rest of the cohort? Because there seem to be some differences. So that's the first question. And second question is, how do we compare with other areas in terms of getting those letters from the NHS or the contact from the GP out?
So what we did with cohorts 5, which is the age group, and cohort 6, which we call the people with long-term conditions and people that don't fit neatly into an age group, how nationally that was decided to roll out is that the age groups would go to people like your pharmacy or your mass vaccination centres, and those people with long-term conditions, the people that have good relationships with their general practice, were contacted by their general practice. So through different routes, and it doesn't mean that you can't have your vaccine if you're in, if you have a long-term condition, you can go to a mass vaccination site, but they went through different routes, and that's how it was worked out nationally to start with. Don't know if that answers your question. So they are running at the same time.
Follow up. So if people who have long-term conditions or are clinically extremely vulnerable haven't had a contact with their GP, should they actually be contacting their GP to say, you haven't forgotten about me?
Not yet, because we're not at the end of that cohort, so we are still running. They didn't all go out at once. So what they have done is they've done them in a staged approach so that they can fill a clinic rather than have all 60,000 letters go out at the same time. So just because you haven't had your letter or your contact yet, it doesn't mean that you won't have that. So I would say that if you've not had that by the middle of April, which is the deadline to complete that cohort, then that would be the time to think that you might want to contact them.
Right, I'm just aware that the regional hubs are contacting the next cohorts down.
Definitely they are.
So can people who are in those cohorts contact the regional hubs and get them there if they haven't heard from their GPs?
They can, absolutely. So if you are in, if you had a long-term condition, it doesn't necessarily mean that you have to be vaccinated by your primary care group. You can go to the mass vaccination site and you can book in through that way. Yes.
Right, thank you. And how do we compare with other places on this?
I think for our, I would say we've done 94%, and that is about, for the Southwest, we compare ourselves in the Southwest, and that would be where we sit with other people in the Southwest. Most people are somewhere in towards the, the top end of the 90%.
Okay, thank you. Ms Wigglesworth, would you like to come in? And then it's Councillor Nichols.
Thank you, Chair. I think it's just obviously to congratulate the organisers of the vaccine delivery programme, but just to pick up Natalie's point around sort of the next stage and ensuring that we don't increase inequality and that we ensure that everybody has enough information and sort of access to be able to have the vaccine, and as part of protecting all of our communities. I mean, clearly over 90% coverage is absolutely fantastic and will really protect those vulnerable groups. As we work down into some of the younger age groups, what we do know from sort of delivery of national vaccination programmes is there can be this sort of hesitancy for a variety of reasons, and it's really important that we all work as a system to sort of engage people who, might have different beliefs about vaccination. So not just sort of marginalised groups, but also people who sort of have either sort of cultural or peer views about intention to get vaccinated, make sure it's as easy as possible in terms of how the vaccine is delivered, and sort of address any of those sort of cultural factors in our work. So I know that I'll be joining with the NHS in ensuring that we do what we can, understanding our communities, and as that rolls out, because it's clearly the future in terms of keeping everyone safe, is to ensure the uptake is as high as possible, as we do with other vaccination programmes. And having worked in sort of infectious diseases in other parts of the region, we know that things like measles are clearly associated with areas like Totnes, like Stroud in the southwest, which have very different views about the usefulness of vaccination, and what we're unlikely to see that type of effect, but clearly there are risks around those things. So really understanding what works well and what the good evidence is to do that is part of obviously my duty as well as Director of Public Health. So Scrutiny might want to have further reports on that as the work rolls out into the future.
Okay, thank you for that update. Councillor Nichols, Sue, please put your microphone on.
Thank you, yeah, and thank you for that, Natalie. I mean, it's really heartening to know. I think there's just a bit of concern that I'm picking up from residents. Firstly, I had mine done at Badrigi, which was the Pfizer one, which was such a brilliantly set up system. You know, I can only praise that, although they're not my surgery. But I think there's confusion because some people seem to be getting dates for second vaccinations and others aren't, and it's just left in limbo. So I think if we can kind of like give some message, I mean, I certainly haven't got one for a second vac, and friends have. So there's kind of like a mixed message out there at the minute. And I think if we could clarify it so people don't think they're going to be left out or whatever, I think it would be useful. And whether, you know, I know at the moment we're saying that they have to have the same vaccine. I don't know how far that's gone down the line in terms of whether it works or not, for, you know, solely sticking to one vax. But it would be interesting, I think, to let people know.
Yeah, so I can answer that if that helps. It is about the vaccine type. So if you go to a mass vaccination site, it is AstraZeneca. So you can absolutely book your second vaccine at the time you book your first one, because you know you're going to get the second vaccine type being the same. In primary care, because they've had a mixture of Pfizer and AstraZeneca, they need to book clinics at the time they know they have the vaccine that will give you the right second dose. So they are doing trials around whether you can mix vaccines, different types, different volumes, etc. But at the moment, it's still, we're still being advised it's the same vaccine. So if you had your vaccine, which it sounds like you did through your primary care network, that's why you've not had a second booking.
Yeah, but I think people need some reassurance that they aren't going to be forgotten.
Yes, yeah.
Thanks.
Okay, thank you. Councillor Ellenborough, Barbara, please.
Thank you. My question is stuff that I am now seeing on social media. Goodness knows I hate social media, and don't we all, about people being able to just go onto the website of the vaccination centres, so the NHS website, to book a vaccination at the places like local to me, Stithians, and be able to book even if they haven't had a letter. And the story also is even if you're not in the cohort. And I think that there's two questions here. First of all, I think we need a very strong statement to say whether that is actually true or not, because if it's not true, I suspect that is causing an awful lot of problems on those booking websites. And secondly, you, because you're the experts, but know what the cohorts are. An awful lot of people don't understand cohorts. And I have to say, both my husband and I had our vaccinations done in our local surgery, the one at Redruth, which is covering quite a large area here. And the efficiency and the way it was organised was absolutely stunning. I think everybody, including the primary care networks, really need to be held up as a shining example of when there's a problem, how well everybody goes and moves together, and particularly all the volunteers who go there as well. I mean, that is outstanding. But as I say, my two questions really about what exactly is the truth about whether you can book online if you haven't had a letter, and
yes, I can help you with that. So the national booking system does rely on people to be honest about the boxes that they tick when they are ticking for their vaccine. So, you know, if they tick that they're in a particular cohort, or then they can get through the the national booking system. However, what I would say is people that turn up at Stithians with a booking are asked to identify themselves with either a letter or some identification. So it is causing some difficulties, if I'm honest, with people, but it will be at the vaccination centre and not at the booking, because we do check at the booking, we do check the booking when we get to the vaccination centre. And so even if you are able to book and you're not in a particular cohort, you won't be able to access the vaccine when you get to the to Stithians.
So could a message be actually put out as a, I don't know, something like a press release or something, or something circulated to all of us as councillors to tell us exactly what the procedure is? Because I think, you know, as I say, I'm sure colleagues will feel the same. They see exactly the same thing, you know, people saying, oh, I went to Stithians and I'm only 40 and I got a vaccination. I mean, that's just I don't know whether that actually happened or not. But as I say, the other thing is what are the cohorts and where are we with the cohorts? Again, would be really, really useful for everybody to understand what the rules are. We're frankly usually a pretty good nation. We like to queue, don't we?
We're quite compliant usually, aren't we?
Yeah, absolutely. Thank you.
Thank you, Barbara. Councillor Martin, Colin, please switch on your microphone.
Hi, thank you for that. Last time we were here together, we asked for a single website to be set up with all this information together in one place, and I've just shared in the chat box there the link of the site that you have put together. I just want to say how grateful I am that is all there now. It says on there very clearly who will receive the vaccine. We're currently vaccinating those in the following JCVI cohorts, and then it lists who's currently eligible to get it. And it says how to get it, ring 119, use the online booking system. So that's all really, really clear. I'm grateful for the answer that you gave to Councillor Ellenbrook just there. So people can book an appointment by falsely ticking a box. When they turn up, the system will flag up and show this NHS number is not in the right cohort. So that's really helpful to know. You talked about people having had their first jabs and then the first 9 cohorts being done by mid-April.
Yes.
That still then leaves quite a lot of other people who are under 50 still to be done.
Yes.
Is there going to be a pause or a delay while we go back round the cycle for everybody to get their second jab?
Well, we will be doing second jabs with first jabs, so there will be no delay. We're overlapping our cohorts, so I know I talk in cohorts, but they're age groups. So before we've finished one age group, we're sending out letters for the next, and they're overlapping, so there will be no delay. The plan is to have everybody over 18 vaccinated by the end of July. Great,
good stuff. That's good to hear. I was also really relieved to see that they've changed the policy on adults with learning disabilities. It was really upsetting to see that older people in care homes are being prioritised, but under 65s that were in care homes, clearly vulnerable, were not. So I'm glad that's been put right. I wrote to you about the situation for teachers in alternative provision schools. and you said that they weren't going to be eligible, and then subsequently we all got a message: get down to Truro Pharmacy tomorrow, you can get vaccinated. So was that a change in policy, or was that something that Truro Pharmacy did through some different means? Had you heard about that change?
I have heard that Truro Pharmacy have done that. It wasn't a change that we made in Cornwall. The pharmacy chose to vaccinate that cohort of individuals. We have said, you know, as nationally they are saying that occupational groups are not eligible through the JCVI.
Mm-hmm. Okay, thank you. And then the last thing was then, you said people can go through the national booking system, and if someone hasn't had a letter from their GP when they think they should have done, they can go through the national system. But just looking at the map, and again, it's really helpful that the website includes a map there showing the different sites that are around. We've now got GP sites evenly spread all across Cornwall, yes. But the pharmacy, there is no pharmacy site between Roach and the River Tamar, yeah. And there is no mass vaccination centre between Wadebridge and the River Tamar. So that does still leave quite a big space in the middle there, where if people have done through the GP system, that's okay. But anybody else is potentially having quite a long way to travel.
Yes, no, we completely agree with you. What we're trying to do is to get more pop-up sites. So we do them quite often. So for particular cohorts, we would have a pop-up site, and it could be in a general practice. But because the mass vaccination sites, there are only 2 of them, we have the ability to have roving sites for those as well. So for instance, if we look at the Eden project, you know, the flu, we did in the car park at the Eden project. So we're looking at things like that, particularly for those people who are able to travel. So cohort 10, what we would call people under 50, we're looking to make sure that we have more equitable spread throughout the county, okay, if you don't go to your general practice.
So I'm just trying to understand, if someone is sitting there thinking, well, I am now in an eligible group, I'm 60 years old, but I don't have a car, and I don't really want to use I'm not sure, how are they going to know that there might be a pop-up site in Liskeard in 3 weeks' time? It seems a bit vague. So I guess you probably can't answer it just now, but I guess the bit of feedback is if there could be more sites accessible through the national scheme in the eastern part of Cornwall, the north and eastern part of Cornwall, that would be good to see those coming on stream. But thank you again for everything you've done, and particularly, I'll keep signposting people to that website as the one source of true information. Thank you.
Thank you, Councillor Martin. Councillor Kirkham, again, switch on your microphone.
I think I'm on now. Yes, good. I think most of my questions have actually been answered about this, but I think it was yesterday or the day before, I'm on the Learning Disabilities Partnership Board. And we had a service users meeting, which was really helpful. And we were talking about the vaccine. And I know that GPs hold a learning disabilities register. And we talked about that. And in fact, I had some information. I think that is cross-referred with the local authority register of service users as well. So I was just going to ask really how people get put on that list. I know that MenCap have issued something to advise people with LD how they can get on that list as well. But I wondered how comprehensive that list is, and whether there are people that are kind of falling through the cracks because they're not on it, and other than self-registering, how they'd be picked up. And the only other thing that we picked up at this service users group was that people with LD or autism aren't identified when they go to the mass vaccination sites. I'll give in extra time, and of course that can cause a little bit of an issue, and I wondered if there was any way of doing that.
Yes, certainly. We do recognise that there are probably people living in the community who would not be registered as having a learning disability, but we do know that most services do know who their customers are. So we are hopeful that triangulating that information with the national and the GP and the local authority, but we would always say that if there are people that people know that are not on the register, then that can be done through the general practice anyway. It can be done through your GP by being put onto the register in that way. We are able to accommodate people with learning disabilities to have their vaccine in any of the sites. So if it is more appropriate that people with a learning disability went, say, to the hospital hub instead, or to the general practice instead of a mass vaccination centre, then absolutely to do that. People need more time, but they also need different things, at the end of the day, at the beginning of the day, to make it the most accessible thing for all of our clients, not just people with learning disabilities. So if there is a requirement for that person to go somewhere else, that's absolutely achievable. We want maximum uptake and we will be as flexible as we can.
Thanks very much.
Thank you, Ms Jones. I have no further questions from anyone. No.
Thank you.
But thank you for the report. It's always good to catch up and get the real figures of what's going on in the COVID world, because like has already been said, they're doing a great job. Some of the things in my local primary care network they've done have been absolutely brilliant. So thank you very much. Pass on our thanks to everyone. Okay, thank you.
Thank you.
Right. Members, we're going on to item 7, which is policy development about the wax removal service in primary care. I think Andrew Abbott is going to lead us on this one. Andrew, your presentation, please.
Thank you, Councillor Toms. Good morning, everyone. My name is Andrew Abbott. I'm the Director of Primary Care for NHS Kernow, and as of the beginning of this financial year, so April last year, we took on delegated responsibility from NHS England for the commissioning of general practice. So for those who haven't met me before, what I'm responsible for within the CCG and across Cornwall and Isles of Scilly are the services we commission from general practice, the budget and the prescribing protocol for all the medicines that GPs prescribe, also the GP IT systems, so the IT systems that the GP practices use, and the development of our primary care networks, and supporting, as you've just had Natalie Jones describing, my team also supports the coordination of the vaccination programme under Natalie's leadership. And I'm also responsible for 111 and out of hours. So those are the sorts of things that I'm involved in. I've been asked today just to sort of provide Scrutiny Committee with a quick update on where we've got to regarding the removal of troublesome earwax. You have a very brief paper which just sort of sets out the key position as it stands. What I've noticed, Chair, and Leanne, I'm happy to send this through afterwards, as I'm not sure whether the appendix that's referenced in the paper has made it into the papers. So apologies if we didn't send that through. I'll send that through afterwards so it can be distributed, because that does provide some sort of further information. So just a very quick sort of summary of a very short paper. Historically, a number of practices have done what's known as manual syringing. A few years back, NICE, the National Institute of Health and Care Excellence, published a guidance which actually said that manual syringing is not recommended and contraindicated, but other forms of earwax removal via microsuction or irrigation or a special probe is the most appropriate. Due to not being the Commissioner of General Practice, and I guess one of the other things, the challenges within general practice is understanding the actual activity that goes on across the 59 independent businesses and the hundreds of thousands of contacts, is we don't have a clear picture historically in terms of which practices did what procedures and for how long. But what has come very apparent to both our attention recently and also to you and your constituents is that the provision of a form of earwax removal service within general practice is declining. What's worth mentioning, and this is again one of the challenges, is that the GP contract is a nationally negotiated GP contract. It makes clear the services that GPs are obliged to deliver under that GP contract. It is supplemented nationally by something called directed enhanced services. So So the requirement now for GPs to work together in primary care networks is an example of a directed enhanced service, and those are optional. Thankfully, I'm pleased to say all our practices are part of a PCN or intend to be very soon. And so those directed enhanced services provide specification on things that are in addition to this core GP contract. So one of the challenges we're dealing with EOVAX removal is it is not a specific service mentioned within the national GP contract or indeed any of the nationally contracted enhanced services, nor is it one of the things that the CCG locally commissions from general practice, which is above and beyond the core contract. So locally we have some things that historically we call local enhanced services, and they tend to be for things where we think they're better value, better experience and more appropriate to be done in general practice than done, for example, in secondary care in a hospital. And for those sorts of things we commission them from the general practice outside of the core contract. And those are things like pre-operative appointments where you get your bloods checked and your blood pressure and things like that. It could be for the monitoring of, if you're on blood thinners, on anticoagulants, you have to have your blood monitored regularly. So we commission that to be done in general practice to avoid people having to go into a hospital. So the range of things that are enhanced services, we haven't ever historically commissioned earwax removal as an enhanced service. So where we find ourselves at the moment is that a decreasing number of practices are providing what they might have historically done in terms of earwax removal. It's not nationally commissioned specifically, and it's not locally commissioned specifically. However, it is one of a number of areas where we believe there might be unmet need. And so what we have taken to do, which has been a challenge during COVID and the pandemic and the vaccination programme, but is actually to review all our locally commissioned enhanced services and to review them for whether they are a relative priority at the moment and into the future, what the pricing or the currency is for those enhanced services, identify unmet need with a view to saying, can we recommission the range of locally commissioned enhanced services better into the future? And so what we have done is to add earwax removal as one of the demands being placed within both that budget and that commissioning area into that review programme. And so this particular issue that we're talking about today will be picked up along with a range of other things which currently are identified as potentially unmet need. The one caution I have to give is obviously we are working with both a finite workforce and a finite budget. Although demand for primary care services doesn't seem to be finite, it's going up. And indeed, personally speaking, I think that is, whilst challenging for the workforce to deal with, there is a general national and local policy of trying to shift more and more care out of acute settings, the large hospital settings, and shift them into the community, closer to where people live and work, and therefore delivered by primary and community care colleagues. And so I think looking into the future, what we might find ourselves is having to make some quite difficult decisions around priorities of what we do prioritise as spending our budget on and what we don't. But one thing I will commit to the Scrutiny Committee and members here is that as we go through that local enhanced review services process, then I will keep you up to date and I can even involve you and others if need be in that review process. So I'll pause there, Chair, if that's okay. I have to add, I'm not an ENT consultant nor a GP, although many years ago I was at medical school, so I won't be able to answer any clinical questions around the removal of earwax. But the paper kind of sets out the position where it is now, albeit what it doesn't do is provide a nice resolution for the problems that people are facing, and I just need to acknowledge that.
Okay, thank you, Mr. Abbott. Very good briefing there. Councillor Nichols, Sue, please put on your microphone.
Morning, Andrew. Thank you for that.
Hi, Sue.
Just a number of things, really. Showing my age now, but ear syringing has been done in general practice since the early 1970s that I remember. And ProPulse machines were bought by most of the general practices in that time, once the manual ear syringing was kind of like frowned upon. I think there's a number of issues. Firstly, most people can't look in their own ears, so they can't see what exactly the problem is. We get a lot of people who come down on holiday who are registered as temporary residents, who when they first go into the pool or the sea and suddenly find that they've gone deaf because their earwax has moved against the eardrum. So are we suggesting that they go to a private ear company or to A&E, because A&E is usually the first place they're going to head for? So I think we need to put out some messages about that anyway. But that ear syringing has always been part of the normal service provided by the practice nurses in general practice. Pro-pulse syringing machines cost about between 150 and 200 odd pounds, so it's not that. I think that half of the issue here is that the nurses in general practice, the younger ones, have never been trained to do ear syringing. I mean, I set up the practice nurses course at Plymouth Uni and have been involved in practice nursing education for many, many years. And I think that's a big issue. But I think that they're going to cause more problems, and they're going to have more problems with people with damaged inner ears and eardrums by doing their own ear syringing, a do-it-yourself course kind of thing with some of the stuff that you can buy. I don't think people realise how fragile ear syringing is. And I don't think they realise that when they stick these, you know, buy it and do-it-yourself machines from various chemists, that they actually realise how much damage they can do to their own eardrums. So I do think a retrograde step, if general practice is not doing ear syringing. And after all, they've got care assistants now who do vaccinations, take bloods and all the rest of it. So I see no reason why that cannot be carried on in general practice. It's not an enhanced service, it's always been provided. And I think, you know, with all due respect, the GPs are looking at just gaining some more money for a service that they already or should be providing. Thank you.
Thank you, Sue. So I'll just come back on a couple of points of those. So I can concur with an awful lot of what Councillor Nicholas has said. I think one of the important things I think that I need to sort of consider is how do we identify the scale of that need that you've talked about, and indeed identify the consequences as you've put out. You know, I get quite worried when I see some of the advertising that I see in social media, in terms of, you know, buy this device off Amazon or any other online retail outlet, and, you know, you can remove troublesome earwax yourself, because as you say, it doesn't take much to stick it just a little bit too far and cause irreparable damage. For this to be sustainable with any provider, whether it be primary care or indeed another community-based provider, you're right, we need to make sure that the equipment is purchased and therefore there's a budget to ensure that that equipment's maintained, that the workforce who use it are trained properly. And I think you're right in terms of when there's a change in what NICE presides as good or not good, that then has implication on training, especially as you've got, as you say, younger workforce coming through. And indeed, it needs to be sort of funded on a sustainable basis. Otherwise, when, as practices are finding at the moment, and you know, the demand for their workforce and their time is outstripping their capacity at the moment, they will start to make judgments around what they can and can't do. So for me, you know, being blunt about it, there isn't a contractual lever that I can say nationally or locally of practices you have to do this. If this is identified as you're suggesting as a priority, and also the consequences of not supporting this are worse than the consequences of trying to support it, then I will be trying to make a case for funding this in a sustainable way. Being honest, the challenge I've got, and this is always the challenge in the NHS, is a finite pot of money and a finite workforce. So we'll need to work out how we prioritise this over some other things. And therefore, that's why I was quite keen to be open in terms of that review process, because we can do that transparently with you and seek your help and thoughts.
Coming back to it, if you look at the quality statement 1 on the NICE guidelines on earwax removal, it does say adults with earwax that is contributing to hearing loss or other symptoms, or preventing ear examination or ear canal impressions, can be taken, have earwax removed in primary care or community ear care services. So, you know, it does impact on a lot of people. And if somebody loses their hearing through wax, especially older people or youngsters, and they kind of like are isolated from society, it is a big issue. And I think the GPs need to consider it very, very carefully. But thanks for that, Andrew.
Yeah, I mean, the only other thing I'll mention, and NICE is really helpful in terms of trying to guide what is good clinical practice and what isn't. However, what NICE doesn't have a responsibility for is to identifying how you afford it.
Yeah.
And so quite often a lot of NICE guidance economically makes sense in the wider system. So I'd agree with you, the economic, the personal, all the impacts of kind of gradual deafness or sudden deafness are huge.
Mm.
And therefore, as a whole system, you would, wouldn't you? It makes really good sense.
Yeah.
But how do you afford it in the meantime? So again, being honest with you, that's kind of where we are. But thank you for your comments. So
yeah, lovely. Thank you, Andrew.
Okay, thank you both. Councillor Loveday Jenkins. Loveday.
Yeah, thanks. Sue said some of the things I was going to say. One of the things that concerns me is about equity, because when people are being told, oh, well, you can get it done privately, yes, you might be able to, but you may not be able to if you don't have that sort of income to be able to spend. So the decisions that people have to make in order to have it done privately, and you know, having it done privately cheaply may be less safe than having had it done in the surgery in the first place. So that there's an equity issue for me, which I think is really important. And we do have a demographic that has a lot of older people who may well be getting increasingly deaf, and maybe that may be you know, partly influenced by earwax accumulation. I mean, it's always happened within the surgeries in Cornwall, in my experience. I mean, my father had earwax removal on a regular basis. I suspect I probably need to, but as I get increasingly deaf. But not every, it doesn't, you know, the putting in olive oil and sodium bicarbonate doesn't work for everyone. It certainly doesn't work for me. It creates more earwax if I put olive oil into my ears. So I think we need some fairness in this. We need to actually be able to ensure that people who need it can get it without having to pay a significant chunk of money. And as Sue said, you know, the NICE guidance says if you need it, you should be able to get it. And at the moment, I don't see that's the case. It's also about what works economically, because, you know, going to your local surgery and getting a nurse to do it in your local surgery is surely cheaper than having to go to a clinic at one of the hospitals and all that entails, both from the person travelling there, but also from the cost of the service. So surely it's a cheaper cost to do it within surgeries with properly trained people than actually having to have centralised clinics and all that entails.
Yeah, thank you, Councillor Jenkins. So I think there's a couple of really important things that you've highlighted, which will be picked up through the Enhanced Services Review. One is to differentiate between inequity and access. So knowing that some practices might still be doing it and some aren't, well, that creates inequity of access. You've also talked around inequalities of those who are able to afford and those who are not able to afford to have it done privately, and as you say, potential consequences, all of that needs to be picked up. I think in terms of secondary care, that service, you're right, it wouldn't be cost effective for a secondary care service to be doing what might be considered routine wax removal. It should be there for the really problematic or where there are contraindications, and so there are quite clear referral guidelines as to when people are appropriate to be referred into secondary care. It's interesting, so in getting deeper involved in this, actually we tend to have family members who are impacted. My father as well, and one of the things in discussing it actually with him, he doesn't tolerate having drops put in his ears, and the reason he doesn't tolerate them is he's, you know, on the pathway to dementia, and actually he doesn't like it. So it's not a case for him that it's not clinically effective. It would be, but he is unwilling, unable, without significant support, to continue the duration of course, which would then be effective, because what I'm told by the ENT consultants is upon putting the drops, or, you know, it actually gets worse first before it then gets better. and he personally wasn't willing to tolerate that. So I think it was a really interesting dynamic in terms of clinical priority versus the social impact of not being able to cope and tolerate. And therefore all of these factors need to be brought into the review. So I guess the recurring theme from me, from the questions raised, is they're all really valid points. I wish I was in a position today to be able to say I found X hundreds or millions of pounds and therefore problem solved. I'm not there yet, but I am committing to saying that we'll review this alongside the other priorities and unmet needs that have been identified, and see what we can do into the future.
Thank you. I pressed the button and it didn't go off mute. Thank you. Councillor John Pollard. John, you're next on the list. Thank you.
Great. Thank you, Armand, very much indeed. Morning, Andrew. I think the impartial observer will be amazed that we're spending all this time talking about earwax, frankly. And I would like just to raise the level a little bit. I pick up totally on Loveday's point, because this is all part of a process, isn't it, which is moving stuff out of the NHS into the private sector. And I totally recognise Andrew's difficulty in balancing his budgets. So I assume that two things about earwax. The first is that every time people have a problem with their ear, they assume they want their ears syringed. And that's not necessarily true. But I also assume that GPs will still be able to diagnose whether you do need it or not. And then from the conversation would direct you somewhere to pay for it. I just wonder, Andrew, whether you would be prepared to comment on that pressure that you're obviously receiving on budgets and how we're moving into that world. I have glaucoma, but I used to go to the hospital to have my eyes checked every year. I now go to Specsavers, but I don't pay for it. The NHS still pays for it. So what are the pressures in getting people to have to pay more for those services that you're anticipating or you're experiencing, if you're prepared to talk about that? And secondly, for the committee, I think it is this broader question of these enhanced services in the future and how many more are going to disappear from the GP services and be put into the private sector. So I think that's something for this committee to take up in the future.
Thank you, Councillor Pollard. So a couple of thoughts. I don't personally see there being a kind of a sort of explicit plan to shift primary care work into the private sector, although many people will believe that there is. Personally, I don't think there is. However, there is a recognised nationally and locally pressure within general practice around, if I were to look back, say 5 years, when I think I presented to committee a while ago in terms of the great news around there now being investment into primary care. So if we think over the NHS over the last, certainly my career in the NHS over the last 15 plus years, there has been lots of investment into secondary care, but not a lot of investment into community and primary care nationally. That's been starting to be addressed with the new GP contract. And so we're grateful to be receiving extra funding into primary care services, funding to create the primary care networks, for example. But the constraint, if I'm honest, at the moment isn't necessarily money, hard cash, it's availability of workforce. And the pressures that we're starting to see within general practice are a combination of demand coming in through the front door, workforce that is reaching retirement age, less people being attracted to come into general practice, a national strategy which we would all want to support, which is shifting work out of secondary care where appropriate into primary and community-based care, but also a desire to do more upfront preventative work to avoid people deteriorating and needing to go into secondary care. And all of these things together make a lot of my general practice colleagues feel, sometimes quite overwhelmed. And interesting your point around the amount of time we're spending on earwax, and I think it's a sort of an example of a wider symptom and set of pressures. So I welcome your steer for committee members that actually we need to look at all these sorts of things in the round. rather than focus on one, because there will be a few other things like earwax that we need to consider together. I don't personally see that there's being a push to try and reduce the amount of work done in general practice and put it into the private sector. That wouldn't be one of my aims. Being explicit, one of my aims is to try and make the case for more of Cornwall's incoming investment to be prioritised around community-based, primary-based and prevention-based care. But obviously that requires us to spend less within the secondary care sort of side of things. So yeah, understand where you're coming from. I think look at this strategically is important, as well as looking at some of these individual sort of areas. But as I say, just to confirm, I'm not feeling a pressure nationally or locally to try and shift work from general practice in the public sector into the private sector.
Excellent. Thank you, Armand. Thank you, Andrew.
Thank you, John. Councillor Colin Martin. Colin, you were the last one on the list for these questions.
Thank you. So I've just got one or two little questions, and then I've tried to summarise it in a resolution. Although the chair's asked me not to sort of do the shared document thing that we've done in previous meetings. So just to clarify, then, are you saying then that you think that you're doing this review of unmet need, and that's going to end up with a new sort of locally enhanced services contract being rolled out at some point in the future, and depending on how much money's in that budget and what priorities you can afford, is that something that you would normally think HASCOSC should have the opportunity to look at? I'm never quite sure where HASCOSC or Health and Wellbeing Board or anybody else gets to look at those things, but it sounds like if you're commissioning things in a new contract, that's the sort of thing we might like to see before it gets rolled out.
Yeah, so you want to come back on that one first, Councillor Martin. Yeah. So we scoped out the approach to doing this review a month or so ago. We took it to our Citizens Advisory Panel 2 or 3 weeks ago, I think it was, to get their views in terms of how we engage people as part of this process and those who are affected by the services. What we're looking to do is not just identify unmet need that we know, earwax as an example, but also identify where enhanced services that were originally specified and commissioned 10 years ago, whether the contractual form, the currency that's used, the specifications, whether they're still apparent and appropriate and relevant. And so we're kind of doing the review from a basis of let's just try and ignore money first and actually review this based upon need, experience, equity of access, and what do we think would be the right model. Coming from that, I anticipate that there will be a number of business cases that might need to be developed, or overarching, why do we think this is a priority? And in that, what I'll be looking to do is to make sure that if the overall spend that we currently spend, we spend about 5.3 million or so a year on these services, if that needs to grow, that there is a clear case to being saying this is systemically better for the whole system. It's better for citizens, it's better for patients who are on pathways, and it should be a lower cost alternative to the consequences of not doing that. So we're trying to do this what I might describe as properly. The requirement from that is both statutorily, if there are any services that we currently commission where we say, do you know what, I think in the future we won't commission that because actually there's a higher priority or the need doesn't quite, then obviously we will have a statutory duty to engage with the population and capital C consult and involve the Scrutiny Committee. Outside of that, Councillor Martin, what I'd like to do is to make sure that the Scrutiny Committee have an opportunity to be both assured of the process we're going through, so that you think, do you know what, that is a proper process and we're content with the process, and then at key milestones through that process that you get a report so you can keep a track on what's going on. I'm also happy if any members of the Scrutiny Committee now or into the future would like to be involved in any of the workshops we have when we start to engage people rather than just professionals around some of these services. So yeah, very happy to do that transparently, because at the end of the day, there are going to have to be some difficult decisions to be made. So that challenge and support from Scrutiny colleagues is always welcome.
Thank you, that's helpful. And then the other bit, I think Councillor Pollard gave a helpful example of where he now gets a service through the optician that he used to get at the hospital, but he seems very happy with that because it's still an NHS service, effectively free at the point of use. Are you saying that in terms of if the workforce capacity in GP surgery is a problem, how feasible would it be for vouchers or whatever to be, basically for the Specsavers, etc., to be funded to provide this service? If the money side of it was fixed, would that solve the workforce side of it, or is that too simplistic a way of looking at it?
So the example given is part of a policy from many years ago called Any Qualified Provider, where the administration at the time looked at the opportunities for competition within the market to try and improve provision and address inequalities. So at that time, the PCT put before us, and the CCG subsequently said, how many qualified providers are there out who can do various things like sort of ultrasound, for example, or hearing aid provision. And as a consequence, what we've ended up with the NHS is a mixed market of some of it done by NHS organisations, some of it done by private sector organisations, but as you say, all funded by the NHS. That could be an option when we look into the future of saying, okay, so if we've identified that unmet need and we can, as you say, sort out the money, do we have providers out there who are willing to deliver that service? One of the key things for me, though, is making sure that we have I guess a provider market which is resilient. And so I wouldn't want to preempt any outcome of where we might go next. But if general practice is unable to deliver something and there aren't alternative community-based providers, it surely is better to have someone able to provide that under the governance and administration of the NHS than not. So, that could be an option we could look at, but it's certainly not a strategic intent of mine, as I say, to commission work from the private sector rather than the NHS.
Yeah, no, and I certainly, that's not something I'm pushing for. I was just trying to understand if there were any other extra obstacles to it. Okay, so I will share I'll read out now. I think nobody else has said they want to say anything. So I'd like to make a proposal for some resolutions. So I will share my screen so people can keep track of what I'm saying. But this is not something that I've worked on with anybody else in the background. So it might be that people want to chip in and say something different. So if you can still hear me okay, then so I'm proposing that the committee resolves that we express concern that some patients are now unable to access services which were previously available unless they can afford to pay for it privately. We express concern that the lack of access to a service may lead to hearing loss, pain or permanent injury, and that the impact may fall more heavily on poorer patients. We express concern that ending the provision of non-commissioned services may be a sign of the financial and workforce pressure currently being faced by GP practices. We welcome the review being undertaken by NHS Cerno to identify unmet needs. We call on the government to provide adequate funding and a workforce strategy to meet the needs of Cornwall's population, including visitors, and we request that HASCOSC be fully involved in the development of a new locally enhanced services contract. So I think that covered most of what people were saying. That's my proposal, but I'm open to anybody that wants to chip in and say anything.
Mr. Abbott, you wanted to come back in.
So far from it being for me to determine what the scrutiny's resolutions might be, but I was just going to suggest, Councillor Martin, on the fourth bullet point, the review being undertaken by NHS Cerno of existing local enhanced services and any unmet needs, because I think it's important we're looking at both. And then in terms of the development of a new locally enhanced services contract, the last bullet point, we might have a range of contracts. So I might just say the development of locally enhanced services, just leave it as development of locally enhanced services. And then it doesn't kind of make anyone assume that this is going to be one particular contract. But other than that, those are my only comments.
Thank you
for making that technically sound.
I have Councillor Pollard wishes to make a comment.
Yes, thank you, Armand. I'm supportive of the comments, and well done, Colin, for writing them up. But I think we ought to recognise that this is not Andrew Abbott's fault. He's a superlative officer doing his best to juggle budgets. So I think we should thank him for his input this morning and wish him good luck in trying to balance these issues in the future.
Thank you, Councillor Pollard.
Thank you. Councillor Kirkham. Councillor Kirkham, you wanted to come in?
No, I was just going to second the recommendation.
Okay. Do we have any further comments from any of the members?
Only for me to ask. I don't think we put people's names in resolutions, do we? So what job title should I put in there, or do I just say we thank NHS Kerno for what they've done?
Yeah, keep it at NHS Kerno.
I'm not sure I want to thank NHS Kerno. I want to thank Andrew Abbott, but I take the point. So I think we could put officers as well, couldn't we? Thank you to the officers for their report. Would cover it. Or the officer even.
Right. Are you keeping it short as that there, Bonnie?
I think I will. I think Andrew can clearly hear how grateful we all are that he's addressed this issue, and that it's revealed a wider issue. It's not just about earwax. It's actually about the strain on the whole primary care system at the moment. So if people can see those words on there, that's my proposal. And over to you, Chair.
Yeah. Councillor Andenbrook, you wanted to come back in?
Yeah, I mean, where are we requesting an update in 6 months, which is what the original proposal was?
Yeah, Chair, what I covered there in the last bullet point was request that HASCOSC be fully involved in the development of locally enhanced services.
Yeah, but it puts no time limit on it, Colin.
Sure, and I'm happy to put a time limit in there if that's what is felt appropriate. I just thought that if this is an ongoing piece of work, we don't want to be left out in the cold and then get a report on it in 6 months' time. What we're saying is we want to be fully involved in developing that process along the way. I don't know if Andrew is able to give us any indication of what timescale he thinks this is happening over, and what might be the most appropriate times for us to be asking for it. We certainly don't want it to drag on into the long grass.
No, so I think I'll agree with both of you. So I think the intention here is that we involve you in as close to as real time as possible. Let's, however, say, and as a minimum, Scrutiny will receive an update no later than 6 months' time. The likelihood is that the first quarter of next financial year will be similar to how this financial year has been in terms of NHS planning, and we still haven't got the planning guidance yet for what next financial year is going to need to look like. But we have committed to the Citizens Advisory Panel and our Primary Care Commissioning Committee that we will get motoring with this enhanced services review. So 6 months as a sort of maximum delay for you, I think, is fine. So thank you, Councillor Edenbrock, just for sort of bringing that back to our attention.
Thank you. Councillor Pollard,
Well, only a word of caution, really, in trying to set timetables for the next committee. There will be a committee because it's a statutory function, but I think it's not within our remit to tell them what to do or when to do it. So I was very happy with Colin's first suggestion, and I think the way you've changed is fine. But I don't think we could insist on a report in 6 months or anything like that, because the committee is its own self.
Okay, thank you. Right, we have a proposal. Leanne, over to you.
Good morning, members. We have amended the recommendation that's on the screen. So they were proposed by Councillor Martin. Councillor Kirkham, you seconded them before there were further comments. Can I just check that you are still happy to second the proposal on the screen, please?
Yes, I am.
Okay, thank you. With that, I will read out each of the points on the screen, so members of the public who are listening and not watching can hear what they are. I will then go to the roll call for the vote. If you could let me know if you are for, against, or abstaining. So on the proposal we have is that The officers thanks for the report. The committee expresses concern that some patients are now unable to access services which were previously unavailable unless they can afford to pay for them privately. It expresses the concern that the lack of access to a service may lead to hearing loss, pain, permanent injury, and that the impact may fall more heavily on poorer patients. It expresses concern that ending the provision of non-commissioned services may be a sign of the financial and workforce pressure currently being faced by GP practices. Welcomes the review being undertaken by NHS Cornwall of existing locally enhanced services and any unmet needs. Calls on the government to provide adequate funding and a workforce strategy to meet the needs of Cornwall's population, including visitors, and requests that the Health and Adult Social Care Overview and Scrutiny Committee be fully involved in the development of locally enhanced services with an update in 6 months as a minimum. Just to go back onto Councillor Pollard's point, yeah, the new committee will be responsible for their own work programme as we were. So you can resolve that, but it would be up to them whether or not they took that forward.
Leanne, sorry, can you just reread the second bullet point, because I think you said unavailable, not available.
Okay, so expresses concerns that some patients are now unable to access services which were previously available unless they can afford to pay for them privately.
Thank you.
Okay, so we'll move to the vote if members are happy. So I'll call you in order. So Councillor Biscoe.
Councillor Biscoe popped out just now to deal with an issue.
Okay, thank you. Councillor Chopak.
For.
Councillor Ellenbrook.
Abstain.
Councillor Gammon.
For.
Councillor Jenkins.
For.
Kirkham.
For.
Councillor Lennox Boyd.
Abstain.
Councillor Martin.
For.
Councillor Nicholas.
I'm abstaining because I'm not quite sure of the wording there. Thank you.
Thank you. Councillor Parsons.
For.
Pollard.
For, and I welcome some explanation for the Conservative group while they're abstaining, frankly, but I'm for.
Thank you. I can't do that right now, but we'll carry on with the vote. Councillor Thomas. Councillor Thomas. Councillor Tom.
For.
Councillor Burr. Councillor Burr, are you on the call? I think you might.
Abstaining.
Oh, abstaining. Fantastic. Thank you, Blair. Just confirming that.
Okay, thank you.
And Councillor Williams.
Yes, I'm abstaining as well, unfortunately.
Okay, so of those in the room, we have 8 in favour and 5 abstentions. There are 2 councillors who aren't present in the meeting and have been unable to vote. So that's carried with 8 in favour.
Okay, thank you. Colin, can you stop sharing the screen, your screen, please? And
Point of order, Mr. Chairman, if
yes.
I may.
Councillor Pollard.
Well, I'm just intrigued, to be honest. I'll be quite honest about it. But clearly, the Conservatives take the decision to abstain, which is entirely their prerogative. But I am amazed that Councillor Nichols led a lot of that discussion and then abstained from the vote. So, could we just have an explanation of that, please?
Chairman, if I may, it's Barbara Ellenbrook here. This is not a Conservative view. It happens to be, I have to say, I'm not happy again with the way that Councillor Martin seems to be changing changing the resolutions. If you recall, at our last meeting, we had all of that as well. So that was my reason. I don't disagree with some of the comments in there, but I really feel that some of them are just not what we should be doing in a committee like this, which is looking apolitically at an issue. That is why I abstained. I did not vote against, but I abstained because I was not happy. And that is a personal view. If other colleagues agree with me or disagree with me, that's absolutely fine. But I find it quite insulting to be accused by you, Councillor Pollard, of the Conservative group all abstaining. We are here as members of the committee and as community, not as politicians.
If I can come back, Chair, I'm very happy to apologise. My intention was not in any way to insult anyone. I'm just sorry, but when all the Conservative members group vote in the same way and take the line of abstention, then it appeared to me then that was obviously a Conservative Party stance, and that's fine. You have the right to do that. I just felt that if you didn't agree with the resolution, and remember there was no proposal on the table apart from to note. So if you didn't agree with the resolution, then it would have been useful to, as a colleague on the committee, if you'd explained that during the debate. I don't want to prolong this, but that was where I'm coming from. It's a matter of understanding, having had a good discussion and a great contribution from Andrew. Just some explanation would have been useful, Barbara.
Right. Well, that is my explanation, John.
Yeah, sure,
I did not. What I'm trying to say is I did not want to prolong the debate with expressing my concern on some of the items that were actually within the resolution. But as I say, you know, we have a lot of business to do, and I didn't feel it was productive for me to do anything than what I've done. I'm sorry, Chairman. I'll now switch my microphone on.
Actually, I'd like to come back in there as a point of order. Firstly, I don't think we should be discussing this in the committee. Secondly, I was out of the meeting at the time and I didn't think that the wording on that was strong enough for what I felt.
Chairman, it's Anita Searby from Democratic Services. Can I just intervene at this point? It's not a matter for members to have to justify how they vote in this arena, so I think you should move to next business.
Okay, thank you. Is everybody accepting of that?
Yeah, I'm fully accepting that. My apologies, Armin. It's just I felt that we were working very well together as a committee. It was a good discussion, and I just felt that people like Barbara's explanation would have been useful before the vote rather than after it. I'll shut up and we'll move on. And I do apologise to Anita because I was probably a bit beyond what I should say.
Okay, thank you, Councillor Pollard. Moving on, we've got a couple of minute break here on my list, and then we'll move on to the Safeguarding Adults Board report. Can we have 5 minutes so people can get a drink or whatever they need to do, and then we'll come to you, Fiona. Is that okay?
Thank you. Okay, thank you, Councillor Toms.
Okay, thank you.
Members, if you can make sure that your cameras are switched off and you're muted, please. And it's currently 11:32, so if you could return at 11:37. Thank you.
Morning, Fiona.
Good morning, Martin. I can't see you, but I can. Oh, yes, there you are. Right. Are you all set with the slides and things? Thank you for helping.
Yeah, no problem at all. Yeah.
Okay. I'm probably going to go through the first ones quite quickly because they've seen some of this before, so I'm hoping they will remember who we are and why we're here.
Okay.
Okay.
I think there's about a minute to go by my watch.
Okay.
Okay.
Morning, Councillor Toms.
Morning. Yes, I'll make it time. So shall we carry on?
I've got a minute left on my clock, Chairman.
I've got a minute left as well. 37. It was very precise.
Okay, I'll concede.
Oh, I've gone to 37 now.
There we go. Just wanted to make sure that everyone got their 5 minutes.
Yeah. Okay, we're ready, Councillor Toms, if you are.
Yes, I'm ready. Okay, carry on. Thank you, Phil.
Okay. Yes. Good. Thank you, Councillor Toms. Right. Good morning, everybody. Hopefully you've managed to make it back. You will remember I have been to this committee before on a couple of occasions. I'm Fiona Field. I'm the independent chair of the Safeguarding Adults Board for Cornwall and the Isles of Scilly, so covering 2 local authority areas. This report now feels very historic because we are the annual report for 2019 to 20, and actually 20 ended the first week of lockdown. So it does feel a very long time ago now that we are talking about. Unfortunately, it's been delayed for very obvious reasons, that lots of things have been delayed and committees, etc., with very full agendas for the current pandemic that is being dealt with, as well as other issues. Anyway, this is our annual report. We are a statutory board, as you know. I have Martin Bassett assisting me with the slides. Martin is our interim business manager. So thank you to Martin for dealing with the slides. Just a very quick slide to remind you who we are. As I said, we're a statutory board. So all local authority areas have to have a SAB, a Safeguarding Adults Board, made up of the local authority. We have 2 on ours, the CCG, which is clearly Cornwall, and Devon and Cornwall Police. Other organisations that can be involved in a SAB are up to the local area to decide. So we have quite a big SAB, and if we move to the next slide, Martin. You'll be able to see on this slide, and I have showed you this before, these are the organisations with the names of the people who represent those organisations on our local Safeguarding Adults Board. We have 23 members, so we are quite a big board, but we also have an executive group that's much smaller that works on behalf of the board. So there you can see the pieces of our jigsaw that make up who we are. Pleased to say that we do have Falmouth University involved. Clearly they have young adults living away from home for the first time, 7,500 of them. We have Cornwall colleges involved, so we take in young adults. We do have a couple of independent providers, because clearly, as you know, the health and social care sector is made up of many individual providers across Cornwall and the Isles of Scilly. So we have 2 there that represent that, and we have a carer who runs carers groups across Cornwall, Wendy Gaunt, that represents very important group of people who are the carers of individuals who are vulnerable, and others besides. Next slide, Martin, please. So that's who we are. So going back to 2019-20, what we've achieved, you'll see appearing before you, if you keep going, Martin, a list here of just some of the things that the board has achieved. I'm really proud of our board. It's very active. It does lots of work. It meets 4 times a year, but as I mentioned, we have an executive that meets in between those times, and you'll see shortly we have a lot of subgroups that do the work for us. So there's just a smattering of some of the things that we've achieved, which you'll be able to read more detail of in the annual report as published and shared with you in the papers for today. So next slide then, Martin, please. We've also set ourselves a new plan. So I've been around just over 3.5 years now. We set a 3-year plan when I arrived, and we've just set a new plan, which is actually 21-24. We lost a little bit of time because of the pandemic last year and decided just last week to retitle it for 21-24. And you can see there that actually exploitation of young adults, we share that priority with children's services, so there's a lot of work goes on with very young children up to the age of 18, but clearly for young adults up to the age of 25 we wanted to take that work forward. It's important to do that. Some of you will have come across with your constituents people who are either neglecting themselves or hoarding, and very often neighbourhoods can be very concerned about those people. There is more and more of this type of behaviour being seen and spotted and being brought to the attention of the police, the fire service, adult social care, health staff of various types, quite rightly. And neglect, self-neglect, is a type of abuse. It is actually recognised in the Care Act as a form of abuse alongside financial abuse, sexual abuse, etc., etc. So it's important to recognise it is a form of abuse, even though the person is doing it to themselves. Most of you will recognise domestic abuse from various other arenas that you're in. We wanted to make sure for us that we looked clearly at people who are vulnerable, who either cause domestic abuse or suffer from domestic abuse, and particularly look at the whole family approach. Mental health is a very big issue at the moment because of the pandemic and what's happened to all age groups and their mental health over the last 12 months. We clearly want to concentrate a little bit on making sure that people are assessed as having capacity to make decisions, sometimes going back to neglect and hoarding, for instance, that they can get the right help in the right time if they don't have the capacity to act for themselves. And something I was keen that we do for this year, there is no date on this at the moment, but actually have a look in detail at the impact of the coronavirus for safeguarding and vulnerable adults in particular. Okay, Martin, next slide, thank you. So you will have a copy of our new strategic plan in your papers. Going back to our annual report that's over a year ago now, you can see there that in the back pages of the report are the statistics around what happened to do with safeguarding concerns and inquiries during the year, and you can see the blue bars there show an exponential increase over 12 months ago. Having just looked at the figures not that long ago for the year that we are coming to the end of now, the numbers have gone up a little bit, but not as much as they have increased year on year over the last 4 years. But nevertheless, there have been more safeguarding concerns referred, and safeguarding concerns can come from members of the public, family, and also professionals as well. So it's that whole group of people. Next slide, Martin, please. Okay, we all want to know, well, where is abuse happening then? So based on those nearly 8,000 concerns that were raised by various people over the year, you can see that the location of abuse, not unsurprisingly, most abuse happens in individuals' own homes. And you can see the box there shows the different places and the different types of abuse that happens. And again, hopefully you can see that self-neglect, the very top box, the orange box, has continued to increase year on year, and also the box that talks about neglect as well. So there's a pattern, a theme there, very much relating to neglect and abuse. Thank you, Martin. So making safeguarding personal is a national approach to making sure that adults who are in the system that supports them if they are being abused are put at the centre of what's happening. It's easy to say that, and one would think, well, surely that's the case. Actually, sometimes the process takes over a little bit from what the person actually wants to happen. So making safeguarding personal very much brings in some values and ways of working to make sure the person is kept at the centre of the process they're in. Not unsurprisingly, we monitor whether people are actually asked at the time that they enter the safeguarding process, what is it you would like to happen? because quite often that question is not or has not been asked in the past. It's good to see in the box on the left that actually, yes, people were asked. You can see the blue, and they were asked, and quite often people are not quite sure what they want to happen, so no outcomes in particular were expressed. You'll quite often find that people say as an outcome, they say, I want the abuse to stop. They don't say things like, I want somebody sacked, I want somebody to go to prison, I want somebody prosecuted for this. They will very often say, I just want it to stop, particularly if it is a family member and particularly if they live with that family member. So you can see on the right-hand side, people were asked there, and then, sorry, Martin, it's the next slide. What happened next? So you can see there at the end of the process, when we go back and say, so was that person's expressed outcome, was it actually delivered? Did it happen? Was it achieved? You can see they take in the blue box, the sort of getting on for 2/3 of those outcomes were achieved. And if you take in the partially achieved, we were pretty much getting to, everybody was getting pretty much what they wanted to happen. Sometimes it's not possible to achieve what somebody wants. If I take into account things like if somebody did want somebody prosecuted in the courts to take up through the judicial system, it's sometimes not possible to do that because we have to have evidence beyond reasonable doubt, as you will be aware as councillors, and there are quite a few occasions when actually that's not possible for the police or for the police to actually get that evidence in the way that it's required to take it through the court system. Okay, Martin, thank you. You'll be aware of Care Quality Commission. It's the regulator for the care sector across the country. I thought members and the public would like to see where Cornwall stands in the Southwest league table, and we're sort of pretty much in the middle. So that's for good and outstanding homes and domiciliary agencies. That doesn't mean to say that all's perfect by any means, and the local authority and the CCG in particular have been doing some very good work with local providers, particularly during the pandemic, I have to say, which I'll be reporting on next year, to actually help improve some of the care that's gone on in the homes in Cornwall and the Isles of Scilly. Okay, thank you, Martin. Although the report is reporting for the year before the pandemic actually took hold, we did actually have work going in right at the end of 1920 about the growing evidence that we were going to have a pandemic globally. March particularly took that into account, and clearly first lockdown happened on the 23rd of March. So again, we wanted to recognise that there'll be much more in this year's report about the pandemic and the work that's gone on around safeguarding adults and trying to keep vulnerable people safe. Thank you, Martin. One of our statutory duties, and you'll see this in the report, is to conduct something called a Safeguarding Adults Review, a SAR, and that's a statutory requirement of all boards to look at. It's when something has gone wrong with an individual, or it could be a group of individuals, or it could be an institution, a type of institutional care. We bring in an independent author, nothing to do with Cornwall or the Isles of Scilly, who will take a look at that case or cases on our behalf and produce a really in-depth report about what happened, what went wrong, what the good things were, and importantly, the lessons learned, a term I'm sure you all recognise, the lessons learned, and most importantly, what we can do to change and improve the situation that happened, so we try not to let it happen again. So we had quite a lot of SARs on the go in 1920, as you can see there, and indeed some of those in 2020 have actually been published, and some of you will be aware of those. So some of those in progress ones are actually now concluded, I'm pleased to say. And they are available on our website. If you'd like to look at those, they're in the public arena. There is one on that list that isn't in the public arena. We can make a decision sometimes when we've had the SAR concluded and presented to our board that we're not going to publish it, and indeed one of those there was the person had a young family and there are children involved in that, and for obvious reasons we're not going to publish that because there are children living in Cornwall. We do anonymise them for very obvious reasons, so those are not the real names, because we don't want to be able to identify particular families or that sort of thing. So we will make a decision not to publish at times, but generally we will publish a report. Okay, Martin, thank you. So that's it, a bit of a whistle-stop tour. I hope you read our report. There are lots and lots of case studies in there. We like to bring it to life, so it talks about work that organisations have been doing locally, most importantly doing work together, multi-agency work, because really that's what makes a SAB work effectively. So any questions from members? Happy to take any questions.
Firstly, thank you, Ms. Fields. I have no questions at this present time from anybody, so you've got away with it very lightly by the looks of it.
Yes, yes. I usually have a couple of questions, so that's fine this time.
Councillor Ellenbrook, you've just come in. Thank you. Barbara.
Yes, sorry, thank you very much, and thank you for the presentation. You're absolutely correct. We have seen this before in some parts, but it's really heartening, and I speak as somebody who has a vulnerable parent, to know just how much hard work is being done to ensure that people are kept as safe as they possibly can. So all I wanted to say was thank you very much. Thank you for being open and honest with us about what's going on, and you know, brilliant work. Thank you.
Yeah, thank you for that. I think when anybody has a vulnerable adult themselves, usually a parent, but it can be a child, you know, or a very close friend, it brings it very close to you, doesn't it? Just how vulnerable we can all become at times in our lives.
Indeed, and I am very reassured that should anything happen with my vulnerable parent, that I could in confidence come to you and get something sorted out, which is marvellous to know.
Thank you, thank you. I think Rob Rochell is here, isn't he? He's the cabinet member for adult social care and health.
Yes, indeed. Thank you. I was only going to make one point, well, probably 2 points really, was that the amount of work that the Safeguarding Board's done over the last 2 or 3 years has been quite astonishing really, and we're in a different place today than we were again a couple of years ago. So a lot of that work's down to, a lot of that success is down to the work that Fiona's done, so you know, thank you for that. But my point that I was going to make generally was around capacity and the continuing challenge that capacity provides in terms of whether somebody's got capacity to make decisions or not. And certainly over the last kind of year or more, that we've done quite a number of, or several SARs on self-neglect. And I think that we've not seen the last of it, but I think for our field staff, it's a constant challenge around whether people have the capacity to make decisions about their own health and well-being or not. And I think that, you know, we rely on people's judgment and their professionalism, etc. But I think it's a note of caution from me that there will be more, because sometimes it is so difficult to differentiate between whether people have got capacity or not. Inevitably will lead us to sadly seeing more people pass away.
Thank you, Councillor Rochell, and obviously you've been very involved with some of the SARs that we have indeed published that have brought that to light, in fact, haven't they? And I'm sure councillors can think of constituents that they know who are people describe as getting in a mess, or, you know, they're neglecting themselves, the sort of early signs of not looking after yourself, and the hoarding is the thing that people begin to spot, because it becomes very visible, doesn't it, that people are literally unable to get into and out of their houses sometimes, and it is incredibly difficult work to work with some of these adults who very often don't want any help I'm all right, leave me alone, is the usual response when somebody's raised a concern. And they're clearly not all right. But actually, we're in the very grey area with adults. Very traditionally, people would say, well, I'm all right. And people would say, well, actually, they do appear to have capacity to make that decision, go away, leave me alone. But actually, in today's world, sometimes it's not okay to go away and leave me alone, because actually, you know, that person is hugely at risk to life and limb, and quite often to other people as well. So actually, that work for adult social care, in particular, health and the police, the statutory agencies, takes time to get a relationship going with those people, to get them to trust that actually you're not just going to come in and march all over their wishes, but actually they do need some help. So as you say, Councillor Rochel, we are seeing more and more of those people, and staff require quite a lot of knowledge about the law and what they can and can't do, and where they can and can't take decisions on people's behalf. And indeed, one of the SARs that was published not that long ago was a Cornish man who actually we took to the Court of Protection because he was saying, I'm all right, I'm fine, you know, and he was literally at risk of death. We knew the next time he came to somebody's knowledge, he'd be found dead literally by the side of the road or in a ditch or a bus shelter or whatever. And that decision was taken away from him by the Court of Protection. But actually, he's lived quite a long time. He's no longer alive, but he lived in a safe, protected environment for quite a considerable length of time. So that was all credit to Cornish agencies to say, actually, we cannot walk away from this man and allow him to make decisions that he's going to die from. Thank you.
Thank you. Thank you, Rob, as well. Councillor Martin, please.
Thank you for that. I don't think anyone would disagree with anything that's written in that report. I just think as we come to the end of our term of this committee, to look back on the state that safeguarding was in 4 years ago and compare it with the progress that's been made since then it's a great relief. We can actually see that, you know, some good has been achieved, and to recognise that sometimes that's been done by people asking difficult questions and you know, opening cans of worms and looking under stones that we didn't want to look under, and also to recognise that the job is never finished, and the day you think that you've got it sorted is the day that people are in danger again. And when I've asked questions previously, you know, can you assure us that nothing like this will ever happen again? The answer was no. We can't assure you that, but we can assure you that we're on the lookout. So thank you very much for that. Yeah, I'll leave it there for a second. Thank you.
Thank you. Yes, I'll pass on your thanks and acknowledgement to the board, because I'm very proud of our board. They work really well together. They're a really committed group of people. Really proud of them.
The change hasn't happened on its own. It's happened because people decided we need to do something about this, and looked at what needed to be done and made it happen.
Yeah, thank you. Thank you for that.
Thank you. Thank you. Councillor Jenkins, Loveday.
Yeah, thank you. I mean, I'll echo the recognition of the hard work that's been done so far, because I think you know, things are moving forward. Just wanted to ask a quick question really about data management, and whether you've now got a better system in place to ensure that concerns are shared across agencies and monitored on an ongoing basis somewhere. I mean, I know within adult social care that they're starting to use Mosaic a lot better for that, but is that spreading out across the other agencies?
I wouldn't say Mosaic is spreading out across the other agencies, but the sharing of information is certainly spreading out across information. I will steal a little bit of the thunder that's happened over the pandemic, really. So it wasn't in the 1920 report, but I know it's happening right now and has been for the last 10 months or so. It is actually, there have been daily sharing of information, telephone calls about vulnerable people, which has worked incredibly well. And Helen Charlesworth-May is here, and I think Suzanne is here as well. And I'm sure they've been talking to you about some of the changes that are coming through in adult social care about more of a locality-based structure for safeguarding, which was planned before the pandemic, but actually it's been proven now that actually that sharing of information in small localities is absolutely the way to go to keep as many people safe as we can. So we are moving a bit from a more centralised structure to a more localised structure, and there are some risks in that transition which everybody has recognised and has been shared. So we know to be on the lookout for if information isn't being shared in the right way, in the way it's been done for the last 12 months. So I hope there's a bit of reassurance in that. We're not there yet, so it's on our radar to do that. From a board point of view, the sharing of information is, well, it's completely different than the way it was 3 years ago. I mean, I can't even compare it because it's just completely different. And information is shared at board level. We have regular performance reports, as you can imagine. All the agencies contribute to that. They all sit on a subgroup that does the challenge, asking the tough questions that were referred to before. So there's some rigour attached to how we're performing as a board and how agencies are performing across agencies. So yeah, as I say, I'm not even going to compare to how it was before because it's just really different.
That's really reassuring to hear, and that that the board are really getting on top of that, because I think that's without having people getting lost in the system or different people's systems and not actually getting that holistic approach that you need at the local level. I think we've failed people in the past, I would say. If we can stop failing people because we are much more joined up, I think that's really heartening to hear.
Yes, absolutely. And I have always come from it as a point of view is it's no good one partner saying we're really, really good at safeguarding and we've got a brilliant system if another part of the system is not equally brilliant, because actually it's a system. So if one part's not performing, the whole thing's not performing. You've got to do safeguarding together. You just cannot do it on your own. So I've always come from, well, if that bit's not strong, we need to concentrate on that, because that strong bit doesn't make up for it. It's got to be the whole thing.
Thank you. So we look forward to an even better report.
Well, yes, looking back over the last 12 months is going to be an extremely interesting exercise. Yeah, definitely.
Thank you, Councillor Jenkins. Councillor Nicholas, Sue, please.
Thank you, and thank you for that report. It's really good, and it's really heartening to know that we've got a board now that really works for everybody, and it's really good. I think the point Rob made is really quite interesting. Many years ago, I went to visit somebody who was hoarding newspapers in very large columns all over his house. Pointed out to somebody in, I forget who it was at the time, Environmental Health. And as they said, it's a very fine line between allowing somebody to live the life they want and that, you've gone over the point of where it becomes a problem. But I think it's good that we've got away from that heavy-handed way that things were dealt with many years ago, so that it was automatically, they were in the wrong. So I think that's really good. The other point I think is about rough sleepers.
Yes.
And we've got quite a few in our area who are kind of like living in tents under bushes and all the rest of it. And it's quite interesting because the local communities keep an eye on them as well. So we get reports about where they are, or if they've moved, where have they gone to. So in a way, it kind of like has filtered down right through to communities, so that everybody keeps an eye on everybody who's got a problem. So I think generally, we're doing a really good job, and thank you for that, and all the staff.
Yeah, it's interesting you're raising the point about homeless. The gentleman I referred to, who was a SAR called Jack in the SAR, actually was somebody who was homeless quite a lot of the time. He did have a home, but he made himself homeless quite a lot of the time, not just in Cornwall but other parts of the country. And he was somebody that we were very careful to not produce the whole report on him, because actually he was a well-known individual. So just by describing him a little bit, it did actually happen to me that one of our carers actually said, "Oh, I know who he was, I think, because she happened to live in the area where largely he lived," sort of thing. So yes, it's good that communities know who these people are. And I think, again, the coronavirus has very much focused people's attention on, it's not thousands of people, but actually they're really important individuals to keep an eye on.
And there are also individuals who don't want help, who say they don't want help, don't want to live in four walls and the rest of it. I mean, we had one, I'm not sure whether he's still around, who the locals were cooking lunch for him.
Yeah.
So so he always got hot meals.
Yes.
It's really good that that's all happening. Thank you.
Yeah, thank you for that. Okay.
I was going to add a recommendation, but I see Councillor Martin's come in, and just the consideration of the committee before we go to Colin is HASCOSC thanks to Safeguarding Adults Board for this report and their ongoing improvement as recommendation 1, and recommendation 2 would be as is in the report, which is that the committee endorses Safeguarding Adults Board annual report for 2019-20 in Appendix 1. So, Colin.
Well, thank you, Chair. You've beat me to it with writing down some recommendations. I've just got one little question to ask that would then make one more recommendation. Is I think we recognise that it's everybody's job to look out for the signs of abuse and neglect, and not just to look out for it, but to share it and pass it on to the right person. Is there one central point that you would like us to be referring people to? As a teacher, my head always thinks of the MARU. Is that the multi-agency referral unit? Is that the one place that you think we should be directing people towards, or is there some other single point of contact that we should be publicising?
There is a single point of access in via the triage team in adult social care, yes. I make no apologies for the fact that 3.5 years ago, the referrals concerns being raised were at about 2,500 people. That was far too low for Cornwall. We're now, as you've just seen the figures, over 8,000. No apologies for that's exactly where we should be. People should raise a concern, even if it's not safeguarding, and many of them are not safeguarding, but I'm concerned about Mrs. Jones hoarding newspapers that we just heard about, or whatever. It creates a real headache for adult social care because they do become the focus for everything, and that will need some degree of sorting out to say absolutely not all of this is adult social care safeguarding, but that's the central point of referral at the moment.
So sorry, what's it called, and what's the
it's Cornwall Council Services. Actually, I can see Suzanne's got a hand up, so she may want to come in at this point and pinpoint it exactly.
I'm just trying to get off. Yes, thank you, Chair. I'm just trying to get off mute, so apologies. So just in response to Councillor Martin's request, there is a central email address and a central telephone number. I will make that available to this committee so that you're aware of that information, if that is helpful. And just to follow up as well from what Fiona said in relation to the changes in terms of safeguarding moving forward to a locality place-based model. So we will be coming to Scrutiny, Health and Wellbeing Overview Scrutiny Committee to update on that within the next month or so. So you will be fully informed and up to date in relation to that as well.
Thank you for that.
Okay, thank you.
Loveday Jenkins has just shared the contact details in the chat, so I'll cut and paste that in there. And I might be slightly out of turn to say this. Suzanne, are you leaving us soon?
I am. Well, yes.
I think you need to hear us say that we recognise the important role you've played in this transformation over the past 3 years. So thank you very much for that. You really have made a difference to people's lives. So thank you for that.
Thank you very much.
Before we go any further, Leanne wanted to come in.
Thank you, Chairman. I was just going to say you proposed 2 recommendations. One was the one on the paper, which is that the committee endorsed the Safeguarding Adults Board annual report for 2019-20. An additional one, which was that the committee thanked the Safeguarding Adults Board for their work. You proposed it, but we didn't get a seconder on those two recommendations.
I'd be happy to second that if I could add an extra third one, that the committee recognises that constant vigilance is required and calls on all councillors, officers, partner organisations and the general public to recognise the important role they have to play in protecting our most vulnerable neighbours by reporting any concerns to, and then I'll cut and paste the right bit at the end, by reporting any concerns to the adult social care team. So Armandi, Chair, are you happy to add that third one on if I second your first two?
Yeah, that's absolutely fine. Any other proposals, any alterations, any other members wish to add to that?
Chairman, Councillor Nicholas has indicated that she wishes to speak.
Oh, yeah. Councillor Nichols, come back in, please.
Thank you, Chair. Yeah, I'm not sure about the third recommendation. It's a bit long and it's something that councillors should be doing anyway. I actually would like to see somewhere that we recommend that all councillors attend the training on abuse that is available.
To be honest, I've done a very similar sort of training in the past, and I think it's very, very valuable training. And I totally agree with you, Councillor Nicholas. If you want to make that an additional recommendation, I'd be only too happy to take that on board, as I know the value of that sort of training.
Yeah, I think so. I mean, I've attended quite a lot of it in my nursing career, but the one, I forget what they're called now. They've changed their names 2 or 3 times, Fiona might remember. But it's the multi-agency 2 or 3 day training. Were they something light they are now, or 12? I forget what they're called now, but the council was actually involved in providing that free training.
That's right. That's right. Yes. If you go on the website, on the Safeguarding website, you'll find the details there. Actually, yeah.
And I actually think that most people should do that if they're on this committee, as well as councillors. So yeah, I'd like to put that in the recommendation somewhere, please.
Is that possible to add, Leanne? Before you go, Miss Field, there was in years past a online safeguarding training that took place. When is it still available?
Yes, for yourselves as council members, yes, there is still safeguarding training available through the council. Yes, there is.
I'm sure I did that in maybe the last council, you know, so I probably need a refresh myself, so it needs to be in there.
The package was very good as well, I have to say, on the Cornwall Council website. It is very good.
Yeah. Okay.
Can I just ask Councillor Nicholas, was there a particular training? I don't want to be too vague. I've written here, calls on all councillors to take part in safeguarding training, but it sounded like you had a particular bit of training in mind.
No. It is training. They should be doing it, and we've got an online, but I forget what the name of the company is now because they've changed it.
Yes, it did change. Actually, you're right. Actually, if you put basic awareness training down, that will cover what councillors would need to do. I mean, there are different types of training, but the basic awareness is the one that we're actually talking about, and it's very good.
Anita Searby, you wanted to come in?
Yes, just quickly, Chairman, I'll leave you in peace in a moment. Anita Searby from Democratic Services. I just wanted to reassure all members that as part of the corporate induction that we're looking at post-election, safeguarding is obviously a corporate responsibility for all members. So that will be picked up as part of induction and ongoing annual development. So I just wanted to give that assurance. Thank you.
Thank you, Anita. I'm pleased to hear that. And Councillor Jenkins, you wanted to come in?
Yeah, I just wanted to make the point that Anita has sort of made, that all councillors are expected to have safeguarding training as part of their corporate responsibility. So calls on sounds a bit weak to me. I think something about ensures that, because it's up to this committee not to do the training, but to ensure that all councillors have had the training. Remind, yeah.
Okay, thank you. Ms. Partner, are you able to do the roundup now, and then you know, if there's no further alterations, we'll go to the vote?
I can. I just wanted to highlight, so you've got 2 on the screen, and then there is the original recommendation on the paper, so that would make 3. And I just want to double check, Councillor Toms, that you are happy with the proposal that you have, so the 1 on the paper and the 2 on the screen, and that I'll read them out in a moment, and that Councillor Martin is happy to second them both, because I know that there was a concern raised by Councillor Nicholas about the second recommendation. So can I just clarify exactly that we are happy with the following: that the committee endorses the Safeguarding Adults Board annual report for 1920, that the committee recognise constant vigilance required and calls on all councillors, officers, partner organisations and the general public to recognise the important role they have to play in protecting our most vulnerable neighbours by reporting any concerns to the adult social care team. The committee reminds all councillors of their duty to take part in basic safeguarding awareness training.
So I think Armand had an extra recommendation and a resolution in there about thanking for the work that was done, but he's got the wording for that.
Leanne, when you actually said the last time, you said about you know, thank the HASCOSC, thanks to Safeguarding Adults for this report.
Yeah.
But I'd like to add that and their ongoing improvement. And I see Councillor Ellenbrook wanted to come in. Barbara, please.
Yeah, instead of putting vulnerable neighbours, should we not put vulnerable residents? I'm just thinking that neighbours implies it's only the people that you live next door to, whereas residents means possibly something a bit more Cornwall wide. I'm sorry, it's probably me being pedantic, but
that's fine. Yeah, no problem. Councillor Nicholas.
Yeah, sorry. The bit about ongoing improvement, that sounds a bit weak, given that they have made quite considerable improvement. So can we strengthen that kind of like wording, please? Thanks.
Just put their ongoing considerable ongoing improvement. Would that be okay with you, Sue?
Yeah, that's fine. Thanks.
Okay. Is that okay, Deanne?
Okay, I'm gonna read it out again, just for the point of clarity. I just want to make sure that everyone knows what they're voting on, and that we know where we are. So the recommendations are that the committee endorses the Safeguarding Adults Board annual report for 1920. The committee thanks the Safeguarding Adults Board for their considerable ongoing improvements. That it recognises the constant vigilance is required and calls on all councillors, officers, partners, organisations and the general public to recognise the importance of the role they have to play in protecting our most vulnerable residents by reporting any concerns to the adult social care team. Reminds all councillors of their duty to take part in basic safeguarding awareness training. Suzanne Wixie has got a hand up, Chairman. Are you happy to let her?
Yes, as Suzanne's been intricately involved in this. Suzanne.
Thank you, Councillor Toms. Leanne, can we just make sure that we pick up the link in the notes in terms of the referral routes? Because we've got adult social care team, it's actually sort of the adult safeguarding concerns. If you look in the chat, Councillor Jenkins has put that in. So can we just make sure that that's reflected? Thank you. Thank you, Chair.
Okay.
Okay, thank you.
Thank you. Can just
over to you, Leanne.
Sorry, just for my thing, can we not use the chat for chatting? It's not available to the public. and they won't be able to see what is put in that. So I can ensure that any information around the routes is put in the minutes, but basically just in that there has been information around how professionals can make a safeguarding referral. So just for information for members of the public that are listening. Just so, are we happy with the recommendations as read? If we detail that the team that needs to be reported to. Councillor Toms, are you still happy to propose?
I was speaking and not on mute. It happens. Yes, I'm happy to make those recommendations.
Councillor Martin, are you happy to continue to second?
Happy to second all that. So the wording now says reporting any concerns to the adult safeguarding triage team. Is that the wording we wanted?
Yeah.
Okay, happy to second that.
And members, Chairman, are you happy for me to move to the vote on those recommendations?
Yes, thank you, Leanne.
Okay, thank you. So I think we should know as members of the committee what you're voting on. I will now go through in order of your names. Can you tell me if you're voting in favour, voting against or abstaining, please? So Councillor Biscoe.
Well, I'll abstain, Leanne, because I've only just returned to the meeting and I didn't hear any of the discussion.
Thank you, Councillor Biscoe. Councillor Chopak.
Absolutely for.
Councillor Ellenbrook.
For.
Councillor Gammon. Councillor Gammon.
For.
Thank you. Councillor Jenkins.
For.
Kirkham.
For.
Lennox Boyd.
For.
Councillor Martin.
For.
Nicholas.
For.
Councillor Parsons.
For.
Allard.
For.
Thomas. Councillor Toms.
For.
Burr.
For.
Councillor Williams. I believe he's had to leave the meeting. Therefore, we have 12 in favour with 1 abstention.
Okay, thank you, Leanne, and thank you, Ms. Fields, for your perseverance and for your presentation. Thank you.
Okay, and thank you, everybody. I will pass on your congratulations and thanks to the full board when it meets again. Thank you very much for your time. Bye bye.
Thank you. Bye bye. We'll go on to item 9, the local government and social care ombudsman investigation decision report. Ms. Wixley.
Yes. Good afternoon, Chair, and good afternoon, members. I'm going to take you through.
Sorry, Chair. Can we get the screen share off?
Councillor Martin, can you remove the screen share, please?
Sorry.
Oh, there. Thank you.
And I've got Betty with me, my PA, who will drive the presentation as we go through the actual presentation. So Betty, if we could get that in slide view, that would be really helpful. So this presentation will cover the local government and social care ombudsman investigation decision report into a complaint against Cornwall Council. The presentation will cover the complaint, the findings, the lessons learned, the remedy and the options available to this committee. So can we move on, Betty? Thank you. So the local government and social care ombudsman published this report and their investigation into a complaint against Cornwall Council on the 4th of February this year. This is included in your pack as Appendix 1. The Ombudsman found evidence of fault causing injustice to Mrs D, and recommendations were made to this long-standing case, which was dating back as long as 2017. The Ombudsman has published this report because they consider it is in the public interest to do so, given the fault and the injustice caused to the complainant and the Council's initial refusal to make a suggested payment. The Council has accepted the findings of the Ombudsman report and agreed to undertake the actions described to remedy the injustice, and this will provide a satisfactory remedy to the complaint. The purpose of this report is to provide the Health, Adult Social Care Overview Scrutiny Committee with the Ombudsman Decision Report, as I've said, set out in Appendix 1, and to provide the service response prior to the report being considered by the Standards Committee on the 4th of March 2021. It's also to inform the committee with the actions taken as set out in paragraph 216 and provided evidence to the LGO Ombudsman. To inform the committee of the improvements to our policy, practice and learning opportunities for our staff, and this is in detail in paragraph 217. The LGSO report will formally be considered on behalf of the Council by the Standards Committee at its meeting on the 4th of March. Although that is only a day following the committee, the outcome of the members' consideration of this report at this meeting will be reported to the Standards Committee to help inform the consideration of this report. So the report summary, it covers 4 areas. One is in relation to the direct payment being stopped to Mrs D. The other area is in relation to the inability to commission a suitable care package in a timely way. The third area is the impact on the carer, both in terms of her employment status and also her informal caring responsibilities, and the financial assessment process. Okay, Betty. The findings by the Ombudsman was that they found fault with the Council as they stopped the direct payment, even though Mrs D had provided the information the Council had asked for and without ensuring it had alternative care and support in place. The Council had not yet carried out its needs assessment and had not yet identified a care agency who could take over the care as promised in July 2018. The Council also failed to tell Mrs D in August of 2018 why it had ended, so causing uncertainty and distress to Mrs D. And the Ombudsman did not find fault in regard to the financial assessment element of the complaint. It was not the fault of the Council and did not include the cost of the disability-related expenditure. Okay, Betty. So the decisions and recommendations, the Council has agreed to remedy the injustice caused by the faults and within 4 weeks of the date of the report, apologise to Mrs D and her daughter for the faults identified and for the distresses caused, pay Mrs D's daughter an amount equivalent to what she would have received if the Council had continued to pay for her care and support that she provided from the dates in the report, review Mrs D's circumstances and decide if the Council should allow Mrs D a direct payment to pay her daughter to provide care, share with its adult social care staff the lessons learned about when Council may consider it necessary to use a direct payment to pay a family member to provide care and how best to get medical evidence efficiently. And the Ombudsman also recommended that the Council pay Mrs D and her daughter $500 each for the distress they had suffered since September 2018. The Council did not initially agree to pay the £500 to Mrs D. These recommendations have now all been put in place. There are legal and government implications in relation to the issuing of this report. These are in relation to the potential legal implications arising as if the Ombudsman is dissatisfied with the response received from the Council, they may recommend further action and issue a further report. Additionally, if a similar complaint is upheld after the actions have been implemented, this could lead to increased sanctions. The report highlights issues the Council needs to be mindful of in the discharge of its legal responsibilities. The steps articulated in response to the LGSO findings should assist in avoiding any similar issues and any adverse findings. In terms of consultation and engagement, the service has engaged with the portfolio holder. The matter will be considered at the Standard Committee on the 4th of March 2021. and financial implications of the proposed course of action. As a result, the Ombudsman Division compensation to the amount of £1,000 has been paid, plus an amount equivalent to the amount that would have been received if the council had continued to pay for the care and support provided. This will be met from the relevant service budget. Options available to this committee is to approve the recommendation. This is the preferred option as it will meet the expectations of the affected service user and the LGSO, and it will help inform the consideration of the report by the Standard Committee, or to decline to endorse the actions taken and recommend some other response to the LGSO report by Adult Social Care. For the reasons set out in the report, this is not considered to be appropriate. So in summary, this was a complex case that involved a number of professionals and organisations, all with the best endeavours to support Mrs D and her daughter. However, on this occasion, the local authority failed to provide that coordinated response, and it has accepted its findings of the LGSO. It did give mitigating evidence to the LGSO, but this was not accepted, and a sincere apologies and lessons have been learned, and compensation has been given to the complainant. So I'm happy to take any questions, Chair, but that concludes the report.
Okay, thank you, Ms. Switchley. I have one person to ask a question. Councillor Kirkham, Jane, please.
Hi. Yeah, just a couple of questions, just to about this specific case. So I see that there are new procedures that have been introduced.
Yes.
Are you satisfied that those are embedded throughout the organisation now and everybody understands what they're doing? Because obviously that's a change. And I was going to ask whether she actually, I don't know what, you might not be able to tell me this because it might be GDPR reasons, but whether she actually got the direct payment awarded to her in the end, or whether the council, because you had to reconsider it, didn't we?
It's still being reconsidered at this moment in time.
Oh, it is. Okay, because that was part of the recommendations. And the other thing is there was a media statement we released yesterday on a local government and social care ombudsman report, but was that this case or was that a different case?
No, that's in relation to financial charging.
So that's the case that we haven't seen yet. Okay, yes. Thank you very much.
Okay.
Thank you, Jane. Councillor Jenkins, Loveday, please.
Yeah, I just wanted to declare an interest as Vice Chair of Standards Committee. You'll be looking at it tomorrow, but also to say that any comments from this committee that would be useful in terms of where we've got to. It's been a long and winding road with Adult Social Care and the Standards Committee looking at the local government ombudsman reports, and we've been assured continuously that systems are improving, and I do think they are, but obviously this case started a long time ago, and it takes a while for things to get through the system. So this was started in 2017 and has only just reached the end of the local government ombudsman consideration. The new policies and procedures, like Jane said, you know, it's important that everybody is embedded within them, and that the way that the culture of the organisation, the way that it operates, is the key change, and I'd like some further reassurance that that's actually embedded now.
I don't know whether Councillor Rochell wants to come in first, but I'm happy to take that question. Councillor Rochell, do you want to come back first?
Thank you.
You're muted, Rob.
Thank you. You probably said, Loveday, some of what I was going to say anyway. I think we've been on a continuing process of picking up issues, dealing with them, changing the way we approach things, moving forward. And then each time we think it's better than it was, which is probably the case. Is it right yet? Never quite. So, you know, and whether they've been, you know, what Fiona was talking about earlier about SARS and these kind of things as well, it's about being dynamic in terms of, you know, did we get it right? No. What have we got to do to put it right? And whether that comes from internal reviews or whether it's from external bodies like the Safeguarding Board or like the Ombudsman, it's been big enough as an organisation to say, yeah, we didn't get that right, but how can we try to make sure that we get it right next time? So I think, you know, you can actually see where the policies have improved over time. Inevitably, I'm kind of, my role ends up being the front face of some of these things when the press get interested. And the question that I anticipate getting is, Councillor Rochdale, can you give any guarantees like that something like this could never happen again? And ideally would love to be in a position where I could say that that's the case. But of course, you know, any of us who've been involved in health or social care for any length of time know that when you're dealing with people, anything's possible. And whether that's with residents or whether it's with staff, you know, there's always that kind of interesting kind of dynamic that what you thought was going to happen doesn't sometimes happen. But I think my key point is around our desire to embrace improvement and put that in place. And where we've got individual members of staff who don't quite get what we're doing, is to work alongside them and make sure that, yeah, it's embedded. And I think that was one of the points you were making across the organisation. And we keep supporting staff because, quite frankly, you know, it's a tough old world out there, and sometimes the decisions that they're making aren't quite right. We get that, but after all said and done, they are human beings, and that's likely to be the case. So it's about supporting them and making sure that, you know, all the time we are improving the way that we look after people. And for me, that's a big mark of the progress that adult social care has made over the last few years. Thanks.
Thank you, Rob. Go on to Councillor Nichols. Sue, you want to come in?
Hi, thank you. Yeah, I mean, I also declare an interest in a way because I'm also on the Standards Committee tomorrow, and I've also been involved with Love Day in looking at how we progress complaints and whatever through the system. I think my concern or interest would be the training of staff in the duty of candour, because if that had happened, we might not have ever got to this stage. And it's not just about online training, because online training is quite simple to do, really. It's about training where people physically meet so that they can discuss issues and look at case studies so that it makes it much more realistic to fit the outside world. So I think if I can have some reassurance that we are going to have some real in-depth training, not just online, then I think that would help as well.
Yes, thank you, Councillor Nicholas. So in terms of the in-depth training, we are reviewing our training plans and development plans. As you quite rightly say, it is not just about training, it's about how we actually embed that into day-to-day practice. So that is being reviewed at the moment. If you look at 2.16 in the report to 2.22, you will see the comprehensive response in terms of what the actions that we are taking as a result of this case. So I hope that provides you with some assurance that we are taking action. In terms of Councillor Rochdale's comment, in terms of can we guarantee that this will never happen again, we are dealing with unique people. Everybody is unique and everybody has a unique set of circumstances. We will do our best and put in place the appropriate policy, practice and training to ensure that our staff have the tools to be able to operate effectively. But actually, sort of, it's very difficult to say would it never happen again, because the situation and the uniqueness of this case are different from the next person.
Yeah, and I think that's something that we all have to accept as well. I mean, you know, from many years of nursing and looking after people, it's very true. Every person is an individual, and you do what you can for that individual, and sometimes they don't appreciate it, sometimes it goes wrong, but that's, as they say, it's the nature of the beast, really, isn't it, in looking after individuals. Thank you.
Thank you.
Okay, thank you. Before we go on, if you look at pages 85 and 86, there are 2 recommendations there, so think about what you would like to pass on to the Standards Committee, please. Councillor Ellenborough, Barbara, over to you.
Thank you very much, Chair. On paragraph 2.21, it talks about establishing medical evidence. Now, one of the things I believe is that one of the problems we have is that the communications, the email communications run by surgeries are different from those run by the consultants and what have you. And my question really is does that lack of easily available communication via email actually cause a problem? And is it something that should be investigated? Is question number 1. And my second question is, do you have, or is there, for want of a better word, an ombudsman type person within Cornwall Council, or a single point of contact, that if people are having problems, that they can actually go to? And I'm thinking particularly in my role as a councillor, is quite often as part of one's casework, you get contacts from residents on all sorts of things. And is there a way in which we as councillors can actually have a one-stop shop person that we can actually go to if we come across problems, if that makes sense?
So yes, in terms of one-stop shop, we have our access service where you can go, and if you've got concerns and you need an urgent response, potentially sort of that's the first place that you can go. If it's a complaint, we also sort of have a centralised complaint service as well. So that is another avenue which you can explore, and they will then get in touch with the relevant officers to enable a response to be made to yourselves. So there is that available, yes. The other question.
Yes, thank you.
The other question that you raised about access to medical information, that was a key component in this LGO complaint and investigation. And as we move forward, there were significant contact made with health, and we need to get that relationship and information sharing when requested in a much more timely way, because that would have informed our assessment of the situation much more quickly and would have been able to respond much more quickly. And we are picking that up as part of the complaint as well.
Thank you. I mean, I'm a lay member of my local PCN, and I know that the GPs tend to feel quite isolated is the wrong word, but they feel as if they're almost a bit of an arm's length service in terms of, I mean, concern was raised with me about when people are discharged from hospital and care packages and what have you, and a lot of the time the GPs aren't properly informed about what's going on. But I think there's a wider thing about the GPs maybe feeling as if they're the forgotten service when we're talking about stuff like this. I could be wrong.
We will make sure that we will do everything we can to connect, well, we are connecting with the PCNs on a local basis through the care coordination centres, so we are having those regular contacts with GPs now, so that has improved. Brilliant, thank you very much.
Councillor Ellenborough, just a question to you. Do you think that communication thing with the email should be maybe a recommendation in this, you know, recommendation 3?
I think that we certainly need to look at how the various different arms of the NHS and the council actually communicate with one another. To be honest with you, I liken it a bit to the road systems that we have. I mean, a lot of the time somebody builds a new estate and puts a spur road on, but doesn't actually think that it's all very well putting that spur road on, but actually that has a knock-on effect on somebody else. And I think it's the same with the communications. I think there's a big case for making sure that everybody is using, at the very least, the same system, because that's where things, I think, get lost. And it's nobody's fault. I think that is what can happen. So yes.
Thank you, Barbara. From memory, I think there are 3 different systems that the GPs throughout Cornwall use, and that could be a thing. So think about maybe a third recommendation on the communication side of it. Okay, thank you very much. Councillor Martin, and then we have Councillor Nichols after you.
Thank you, Chair. Perhaps Democratic Services Officer could just clarify, are we purely making recommendations to tomorrow's Standards Committee for their discussion of what action they're going to take towards council employees and members, or is it appropriate for us to be having that broader discussion of recommending changes to the NHS IT system and whatever? So I'll leave that to Leanne to answer before people decide what other recommendations to tag on. I think my concern listening to this story is that yes, absolutely, people make mistakes, and sure, people will make mistakes again in the future. The question is, how long does it take the organisation to admit that it's made a mistake and things right? And 3-4 years down the line, it sounds like actually the council was still arguing to the ombudsman, we did the right thing, we've got evidence that says, you know, here's our mitigating evidence why you shouldn't find against us, and that doesn't quite match up with that that sort of message of, yeah, we put our hands up and we recognise we've got things wrong, we'll put it right as quickly as we can. I mean, someone asked a question earlier, it's still not quite clear if Mrs D is going to be able to use a direct payment to pay her daughter to continue providing the care, which is what she wanted, or whether in fact the council is still going to go ahead and deny them that opportunity, but they're just going to make sure they've got the paperwork right this time round. So that's just my challenge, really. We don't necessarily need to go into it now, but the challenge is, are we sure that we've got a culture of a council that recognises when it's made mistakes, rather than holding on for several years until someone forces them to turn around. And I like what Barbara Ellenbrook was saying about, is there someone internal that can be sort of gone to give that sort of challenge? And they seem to be saying if they'd made a complaint to the council before they went to the ombudsman, then there would have been someone one step removed within the council that would have made that challenge. Are we saying that they went straight to the ombudsman without using the council's own complaints procedure, or did they do that and the independent person within the council backed up the way that our team were doing it, and it was only when it got to the ombudsman that we were told we'd done it all wrong?
So I'm happy to come back on that. Just in terms of, it was in 2017 when the original representation came in. Our legal department have been heavily involved, so it's not just the Adult Social Care Directorate making a decision independently of itself. Our legal department was involved in terms of offering advice and guidance in relation to this case. Yes, we did go back and provide mitigating evidence to the LGSO, but they did not accept that. And when you look at the case in its entirety, the fact is Mrs D didn't get the care and support that was required. and on that basis, that's what the LGO has found us, wanting in terms of our response. But the issues leading up to it and the way that the case was handled, there were mitigating circumstances, but the LGO did not accept that.
Okay, thanks. And
Okay.
I guess the other bit that then the organisation needs to learn is if we go to our legal department and say, we're facing some challenge here, does the legal department understand their job is not always to back you up? Yeah. Their challenge might sometimes be to say, actually, have you got anything wrong here? But again, we're going into details that I don't know about, but just that culture of, Cornwall Council's legal department shouldn't automatically be assuming that Cornwall Council did the right thing in the first place. And sometimes we need to be challenged and say, maybe put your hands up and say that a mistake's been made. Anyway, thank you very much for all that.
Thank you.
Okay, thank you. Leanne, you wanted to come in.
Thank you, Chairman. Just to say that there are two recommendations on the paper. One is that the primary is that the recommendation that recommended actions taken by adult social care and the learning arising from the local government and social care ombudsman be endorsed by the committee. So that's about the fact that there has been learning from the incident. And then the second one is related to the standards committee. So they're not both. So that the Health and Adult Social Care Scrutiny Committee recommend this endorsement so that learning has occurred or otherwise to the standards committee when they consider the report tomorrow. I've just had a quick look. I'm not involved in standards committee on a usual basis, so I've just had a look in the constitution in terms of their power. So it is that they do consider complaints from the local government ombudsman, including the outcome of investigations in which maladministration and injustice have been found, and make appropriate recommendations to the council on the handling of the complaints. Let me just double check anything else. So, and they have the power to make payments, otherwise settlements where maladministration has been found. So in terms of the complaint itself and how it's been handled in terms of them looking at maladministration, from my reading of the constitution, I would say that sits with them. So it would be, our focus would be on whether or not effectively the committee endorses or accepts the learning that has happened as a result of the incident, and then the local government ombudsman's report.
Okay, thank you for that advice, Leanne. Councillor Nichols, Sue, you've indicated you want to come in.
Thank you. Yeah, I mean, I was just, I think after all the discussion, I just think we should move to the recommendations as laid out in the report.
Hey, thank you. You're going to propose that, do you?
Yes, I will. Thank you.
Okay.
Point of order, can I just clarify? It looks like an either or. Are we not saying either we accept what the report is saying, we're picking option one, accept what the report is saying and send that to the standards committee, and if we pick that, then we're not picking option two, which is refuse the report and recommend something different to that standards committee. So Councillor Nicholas, are you going with option one there?
Yeah, but it's going to the standards committee anyway.
Yeah, that's right.
So yeah, option one, I'm fine with option one. Yeah.
Lovely. I'm happy to second you on that, Sue. Thank you.
Thanks.
Before we go any further, because I'd love Councillor Jenkins wanted to come in. Leanne, please.
I was just going to say that I think, yeah, so the recommended actions taken by the adult social care, and the learning arising from the local government and social care ombudsman report be endorsed by the committee, and then you could add on that recommended, and this is recommended to the standards committee, or that the committee recommends to the standards committee that, and that would remove the second. I mean, if you didn't want to endorse it, then you could tell the standards committee that.
Okay.
Leanne, yeah.
Thank you for that. Councillor Jenkins, please.
Yeah, just to follow on from that, really, that the recommended actions, if they're endorsed by this committee, then item 2 basically says that this endorsement should go to the standards committee. I think it's also useful if there's any other comments from this committee that can also be considered as part of that. But you know, if this committee are happy with everything that's in the report and the recommended actions, then that's the most useful thing for the standards committee. The standards committee can actually provide advice to different departments about changes in working practice to reduce the likelihood of any LGSCO cases in the future, because part of the aim of the standards committee review and the working party looking at adult social care was to reduce the number of cases that went through the council complaints system and then to the LGSCO. So it's important to recognise it's part of a whole process, and I think the question about could this have been dealt with at complaint stage within the council rather than having to go to LGSCO is the right question, because the ideal is that you don't get a complaint in the first place, but if you do get a complaint, it's dealt with internally and doesn't have to go out to the ombudsman. So anything that the department are doing, the adult social care department are doing to reduce referrals to the ombudsman is beneficial to the council.
Okay, thank you, Councillor Jenkins. Councillor Ellenborough, Barbara, you wanted to come back in?
Yeah, I mean, I'm not very good at writing what these recommendations should say, but I do think that I would like to see something that says that one of the recommendations we would make to the committee to look at, the standards committee to look at, is perhaps a clearer pathway if people have got complaints, so that they know exactly where they can go, because that might have been the reason why this went straight to the ombudsman, because they did not know how they could make a complaint. And secondly, my other point that I made earlier on about ensuring that the IT that's being used are interact together. I mean, I'm no expert on any of this IT stuff, but I am aware that the PCNs or the GPs have a different, some of them have several different email platforms or whatever the heck it's called, and I believe the hospital has something different. And again, if you're looking for people to communicate well and efficiently and effectively, then it is a matter of urgency that a single platform, if that's the right word, is used across both primary and secondary care. But as I say, I don't know how to write these things. It's not in my skill set.
Yeah, Suzanne Wixie, please.
Yes, thank you, Chair. Just for a point of clarification, Chair, in relation to this case, it went through the council complaint system before it was referred to the LGSO. So the LGO will not look at cases unless it's actually been through a normal process in the first instance. So this case did go through the council complaints process.
Could I ask while you're Suzanne, the issue with the email, it seems to be prevalent here. Could we make a recommendation to the standards to look at the process that communicates between the different elements of this complaint? Yeah, you know, I mean, it's, you know, like I've said, there's 3 different systems. Do they all speak to each other? I very much doubt it. You know, and how do we integrate with 3 different systems? You know, it just seems a reasonable question that Councillor Ellenborough raised, or the system that Councillor Ellenborough raised, that we look at that to say that might be an area you could look at. Okay. Are there any further comments?
Yes, please, Chairman.
Yes, Councillor Biscoe.
Yes, Chairman, I'm a little anxious about this. It seems to me that the notion that Councillor Ellenbrook is trying to include in here about communication and shared platforms and so on actually encroaches on the next item on the agenda, which is the NHS care bill, and that probably we'd be better off raising that in that item rather than this one. I mean, in the end, this is a local government ombudsman finding, and I mean, everything that the local government ombudsman has recommended has been enacted, as we have been assured by the person who's given the report today. Equally, I'm aware that you can't actually get the local government ombudsman to take up a case unless you've already exhausted the complaint system in the council. So they, and it is the duty of all officers to understand what the complaint system is, and if there is an issue, to point out to people that they can use it, and indeed to guide them towards using it. So I think that we need to be careful about what we send to the Standards Committee, and equally, if I could say that I think that as it's written on the paper, the second part of the recommendation, which says that the Scrutiny Committee recommend this endorsement or otherwise to the Standards Committee, I think we should pass our conclusions, what would it be? Our resolution to the Standards Committee. I don't think we should be recommending or doing anything else. It's there for them to consider, not for us to try and influence their decision making. So I think I'd prefer to just say pass these recommendations to the Standard Committee. So I'm a bit sceptical that we should be adding too much to this. The Ombudsman's done his job, and we're noting his report, and we're noting that everything's been done that he's recommended, and we're noting that the department is taking steps to learn lessons and bearing in mind that every case is unique and situations will always arise. They're doing their level best to avoid this sort of one.
Okay, thank you, Councillor Biscuit. Councillor Nichols, you wanted to come back in. Councillor Nicholas, sorry.
Yeah, thank you. It was just to make the point that actually a lot of GP surgeries are already changing their systems from the waiting room to patient stays, which gives a lot more information. And I think it is part, if I remember, of the EMIS system, which will hopefully be marrying in with other people. I mean, there's always been mismatch between the IT systems. And if you remember, the NHS spent hundreds of thousands trying to get it right and still didn't marry up. So I think that's something for the future. I think it is something that does need raising, in as much as we get reassurance that it's all being done towards one particular system. But I think for this one, we just need to go with the recommendations.
Okay, thank you, Councillor Nichols. So are you going to propose this recommendation, the first one?
Yes, I think I did. Thank you.
Okay,
which I'll second.
Yeah, and apologies, I was reading the wrong page. I was looking at the two options rather than the two recommendations, which is why I was saying it seemed like an either or. So looking at the recommendations that are there on page 85 and 86, well, I was going to second it, but it sounds like Bisco has jumped in and seconded it anyway.
Okay, right. Before we go on, Councillor Ellenbrook.
Yeah, Chair, I'm quite happy to not have what I've said included in the recommendation. I'm not precious about it. It's whatever the committee feels is right, so I'm not going to prolong it.
Thank you, Councillor Ellenbrook. I'm sure the people that are involved tomorrow will heed what you've said, and it can be taken up on the next agenda item as well. Leanne, over to you.
Good afternoon, councillors. So the recommendations that I have in front of me is that the committee recommends that the action taken by adult social care and the learning and rising of this, the local government social care ombudsman, be endorsed by the committee. And then the second one would be that the Health and Adult Social Care Overview and Scrutiny Committee recommend this resolution to the Standards Committee when they consider the report on the 4th of March 2021. Does that, Councillor Nicholas, you've proposed, Councillor Biscoe, you've seconded. Can I confirm that that's the case?
Yep.
Yeah.
Fantastic, thank you. Okay. Chairman, are you happy for me to move to the vote?
Yes, please, Leon.
Okay. Councillors, I will read your name in turn. Please can you tell me if you vote in favour, vote against or abstain? Councillor Biscoe.
For.
Councillor Chopak.
For.
Councillor Ellenbrook.
For.
Councillor Gammon.
For.
Thank you. Councillor
Was that Councillor Jenkins? Sorry.
It was indeed.
Yeah, 4.
Thank you. Councillor Kirkham.
For.
Councillor Lennox Boyd.
For.
Thank you. Councillor Martin.
4.
Nicholas.
For.
Councillor Parsons.
4.
Councillor Pollard.
4.
Councillor Thomas. Councillor Toms.
4.
Councillor Ver.
4.
Councillor Williams. I think you said to leave the meeting. Okay, that's 13 in favour and carried. Thank you.
Okay, thank you, Leon. Go on to the next item, item 10, the integrated care system. Who's tabling this one? I've lost my piece of paper.
I think Carolyn Andrews might be present to take that item, Chairman.
Yeah, I've just found it. It is Carolyn Andrews, so I'm sorry about that. I'll put it with other papers. Caroline, over to you.
Good afternoon, everyone. I understand that Helen Charlesworth-May was probably going to be covering this off, but I understand that she's detained at another meeting, so I've been asked to come and just talk you through the paper that you've got in your packs. So you will have seen the paper around integrated care. So if I just give you a slight bit of context for it. So at the end of November, you'll recall that NHS England asked for engagement from council colleagues and health colleagues and wider partners about whether to make an integrated care system a statutory function in the future, and colleagues from the council and colleagues from health responded to that paper and the 4 questions that were within it on the 8th of January. Very shortly after that, all of that information was collated from STPs and providers up and down the country, and a white paper went to Parliament in February to be looked at and to be signed off. So the white paper came out on the 23rd of February, I think it was, and it essentially laid out a framework for integrating care across the counties and the country, and talked about how we would bring health and care closer together, but also those wider provider organisations. It's talking about primacy of place. So we've talked earlier on in this meeting today about place-based care. And effectively, that's where we want to have the centre of the care for our citizens in Cornwall and the Isles of Scilly. So the paper that's come to you today is simply a shortened version, a summary of the 4 themes that came out from that white paper. And those 4 themes are integrating care, reducing bureaucracy, improving accountability and enhancing public confidence, and then there's a section in the white paper about additional measures that the government want to put into place to support that integration. And the white paper really gives us an outline at this stage of what the government is looking to do, and there is future legislation to be added to it around public health and the Better Care Fund. And there is also further guidance to come out around how that integration is going to take place. So effectively, it's talking about integrating in two ways. It's integrating the NHS and health partners, providers together alongside the strategic commissioning functions. And then the other statutory function, which would be a new function, would be the Cornwall and the Isles of Scilly Health and Care Partnership. So that's the two ways we're talking about integration at the moment. And what they're talking about in those two ways of integration is that there would be an NHS body and there would be a health and care partnership. Now, in the white paper, you may be aware, you may not be aware, but NHS England and NHS Improvement will come together and simply be known as NHS England. And then the new NHS bodies that will be up and down the country will be NHS and then whatever the county is. So we may be NHS Cornwall or we may be NHS Cornwall and Isles of Scilly. And then the Health and Care Partnership will become a statutory entity as well. They've given a very brief overview of what those integration bodies will do. So effectively, they're talking about the NHS body kind of running the accountability elements of it, talking about the kind of funding and the allocative responsibilities. And the NHS body will have a unitary board that will be made up of NHS providers and commissioners. And then the Health and Care Partnership is that wider and broader board makeup of health and care, obviously public health. It will include things like the voluntary sector forums, care. It's up to us how we develop that partnership board and that partnership function. NHS England have said that they will mandate the NHS body board and how it's constituted and how it will be recruited to. But the Health and Care Partnership is the permissive and flexible bit that the government are allowing each of the counties to form their own views on that. So I think the reason that it's come today is because that's it very simply laid out. Clearly there is a lot more to it than that. But I think what we need to understand is what those next steps would be. So those next steps will be about engagement and about understanding people's views around the boards and the council boards and the council functions, around how we see that working together best for citizens of the Cornwall and Isles of Scilly. So that's really the update that I have been asked to give. If there's any questions from the paper, clearly, then I'm more than happy to take it. Or if there's any further information that I can provide to councillors, then I'm happy to do that too. I'm just conscious of your time.
Okay, thank you. Any questions from members?
Yes, Chairman.
Yes.
Right, I had raised my hand with a.
Oh, yeah, it was X in the box that I'm looking at.
Oh, I beg your pardon. Oh, sorry, I must have missed that instruction. I apologise. So, Chairman, I think that I have been alluding to this moment all the way through the life of this committee. And it seems to me that this is a key piece of legislation to address a fundamental issue in terms of the future management of British society. I think there's heightened interest in it because of all the issues around COVID and so on and so forth, which means all these things are in the forefront of people's minds. And I think this is a crunch moment for Cornwall. And I don't think it's just a matter of setting up boards and so on and so forth. If you take a hard look at how the health service is organised in Cornwall, Cornwall and the Isles of Scilly do not have a health service. What they have are fragments of a health service, and possibly the west of Cornwall and the Isles of Scilly has got a better health service than the east of Cornwall, which has to go to England to get it. This is purely in terms of Derriford and so on and so forth. Of course, there are GP surgeries and so on. And the issue for me is in terms of organising this, as I think the white paper is anticipating it will be organised, is that either Cornwall will have to, in terms of health and care, cease to exist and become part of a greater whole, which I think is completely unthinkable to the vast majority of people in Cornwall and the Isles of Scilly. Or we're going to have to look at how we structure the health service in Cornwall so that actually we've got a health service which is equally as tailored to the geography of Cornwall as is Cornwall Council, so that actually we can have a meaningful partnership and provide a meaningful service to all the people who will have a right to access it and indeed have a right to call it to account. So I think that this needs to be thought through very, very seriously by Cornwall Council and with our partners in the health service. I'm very conscious that many people in senior positions in the health service agree with the view that we need to strengthen the provision of the health service in Cornwall in order to make it more efficient and therefore more cost effective, not to mention care effective, and that we need to probably undertake this very urgently and then jointly engage in a discussion with the government about how we are actually going to retain the functionality of Cornwall and the Isles of Scilly as the sort of entity which it is, has been and wishes to be on the one hand, and how we do that with government investment in order to make sure that we can make the changes, the provisions, the extra provisions in the health service provision in Cornwall to ensure that we can actually provide a high quality, equitable service which is equal to that people receive elsewhere in the United Kingdom. So I think this is a crunch moment, and I think we've got some really serious and quite high level strategic and constitutional thinking to do, because I think the consequences of this will affect the way in which Cornwall and the Isles of Scilly are able to shape up holistically and constitutionally and politically to their future. So I think it's a really serious piece of legislation, and I hope we do take it seriously, Chairman, and I hope that we do involve people outside of the council, and I hope that we do look at it in constitutional as well as in healthcare terms, because I think it's got a great many implications. Thank you.
Thank you, Caroline. Do you want to? Is there anything you want to? It's more of a.
Yeah. So thank you, Councillor. So absolutely agree with you. It's a huge piece of legislation. It does need careful looking at, and it is a wider conversation that we need to have. The whole point of the paper, you're clearly familiar with it, is that it's about primacy of place. So it is about delivering care as locally and as close to home and as close to the person as we possibly can. So there is a lot of work already going on around that, which we've done and is working really well. What we need to do is build on those good foundations that we've got here in Cornwall and the Isles of Scilly. But there's a huge amount of work to do to make this happen. And there will need to be, as you rightly say, a lot of engagement and a lot of communication about it. There needs to be regular updates to people as to what's actually happening. And that's one of the things that we're looking at the moment.
Okay, thank you. Moving on, Councillor Kirkham, Jane, please.
Hello, thank you very much. Right, yeah, a few things. It is massive, isn't it? The white paper doesn't seem to say very much about public health or social care. Obviously, public health and social care are not funded in the same way as the NHS. And social care is something that the government have been talking about changing the funding for a long time. So it's very difficult to see how this can work effectively if there are still going to be those tensions over money and the way that funding is given. I was going to ask some specific questions about the board, because obviously there are decisions to be made. I've got a number of questions, but one of my questions was, we have a health and care partnership and then we have NHS Cornwall and a providers group underneath. Who makes the commissioning decisions of where the money will go? I was going to ask the questions.
I think we've lost Councillor Kirkham.
I think we've lost Councillor Kirkham.
So will I wait for a minute and see if she comes back?
Just to see if she does come back. No. No, it
Chairman,
doesn't
she's
look
still
like.
listed. Sorry, she's still listed as being on the call, but obviously she's frozen in time, asking her questions. So do you want to move on to another member and then come back if we can get Councillor Kerr?
Oh, there she is.
There's movement.
Why does that always happen? The moment I come on, my stupid internet decides to mess up. Yeah, so the questions I was going to ask, there are some big questions that we need to talk about. So who goes on our Health and Care Partnership Board? Will it be the same as the Senate? How many elected councillors will there be? And my question was, who will do the commissioning? Will that be the NHS Cornwall body? Will it be the providers, the group of providers underneath that? I was going to ask about, because this talks about the ICS transformation director in this paper, and I wondered, are you the transformation director?
Sorry, I thought people knew who I was going to be. So my name's Carolyn Andrews. I am actually the System Transformation Director, and as I say, I've been drafted in at short notice for Helen. So if I answer some of the questions that you just posed. So this is just a paper that has been drafted, and it states quite clearly there's further legislation to come. They're hoping to have the policy framework out by the middle of April. How it's going to be funded is a huge question, and is dominating quite a lot of the conversations with regional NHSE colleagues and national NHSE colleagues, because clearly we've been told there is no more funding. So actually, how does this kind of come together and constitute itself? Because I think there was a view that integrated care system would be a new thing. Well, it's not. The integrated care system, it's all of the current providers and commissioners and delivery service partners that are here already, but it's just bringing us together in a slightly different way. Where will the money come to? Again, there's a question over that. Some of that will come to the NHS body, but there is also talk about delegation down into the place-based care arena, so into the integrated care areas, to enable them to actually, deliver services and work what's best for them in their integrated care area, because there will be different drivers. This is definitely not a one-size-fits-all. And those are the conversations that we collectively now need to start having, because it is about how do we work more closely together? How do we deliver a better quality and service to our citizens in Cornwall? And how do we use our resources collectively to the best that we possibly can? And when I talk about resources, I'm talking about workforce as well as money. And we're all aware, that money is a key issue for all parties. So how do we get best value for that? And we have to make sure that that's what we're doing. And, there's going to be some very difficult conversations that we need to have over the next kind of 6 to 8 months. But we have to be able to have those in an honest and open and transparent way, because that's the only way we'll actually move forward and do what's right for the citizen.
Yeah, I mean, I was having some questions about that. First of all, about accountability. If the money moves down to the ICAs and the providers, now at the moment the CCG is statutorily accountable, but they won't be. So how do we control what they're spending our money on? That's the first thing.
So that's a key question that we haven't got an answer for right now.
Section 75s, will they still be used? Because obviously we've had some issues with our Section 75s in Cornwall and who's paying for what recently. And that is a great concern if the way that the money comes in and is spent isn't changed. So I was worried about that, and the engagement part of it, because if we're looking at us having control over how we constitute this partnership, how are we going to engage not just with the people who are within the sector who we normally engage with, but it has to be wider and bigger than that? How are you going to go out to the public and engage during the tail end of hopefully the tail end of a pandemic? So I wanted a bit more detail about how that would be done, really.
Okay, so the white paper is really clear about joint posts across NHS providers and commissioners, and across obviously health and care. So there is an absolute ambition that they will still be joint posts, and it will be across a wider group of organisations. So again, there's they've been really clear that there will be an HR guidance paper to come out, and that they're anticipating that'll be out in April to talk about how joint posts, how they will view what will sit where from a people perspective. So we've got a white paper that has probably got more questions than it has answers in it at the moment, which is not easy to work with, but it does give you a bit of a roadmap as to how we need to start the journey. With engagement, then clearly, as you say, it's got to be a wider engagement. At the moment, we've just obviously started to pull together what the key components are of it. And just to go back to Councillor Biscoe's point, he's right, it's not just about boards, it's much wider than that. But clearly that's kind of, we need to understand what we've got now. And we already have a bit of a health and care partnership board. So it's kind of what we've got and what we build on. But from an engagement perspective, we need to talk to all of the partners that are involved in it currently, and we need to talk to wider partners because it's going to look very different. You know, it talks about making sure that we've got an economical development in there. So, you know, we need to understand how those links for that comes in. So, you know, we've already doing some work around with DWP about how we, you know, use unemployed people in a different way, but it needs to be wider than that. And we are at a start of a journey. So we do need to build this together. This is not about health colleagues going away and going, right, well, this is what it looks like. Because if you read it, it can read, you know, as a predominantly health kind of paper, but it's not. You have to recognise it's wider than that. So we need to make sure that we bring and hear all of the voices that needs to be included in it, and it is that wider group.
That's one of its failures, isn't it? It completely ignores things like, well, social care and public health. Really, there's not in it. Sorry to cut across you, Councillor, but just prompted something in my mind because you've asked this question and you've just mentioned it again. I think the reason that there's not very much about public health in it and about adult social care is because obviously the way public health is going to be constituted is in train at the moment. So I think what they've wanted to do is, because it's moving to the Public Health Institute, I think they didn't want to put too much in there until that had been done. And I think as far as adult social care is concerned, obviously they've said there that it absolutely needs to be part of the, you know, the integrated care system, and it is moving that way. You know, we've got a reasonable relationship and about how things are done, but there's more work to be done on there. And again, it says in there that, you know, there will be further guidance about how that will work. Okay, great. And I was thinking that this partnership board looks like it might be akin to the Health and Wellbeing Board, which is a bit kind of floating at the moment. It's a bit unclear about what its job actually is. So it would be nice if we could pin down what this partnership's job will be actually be, or will it just be kind of a talking shop and all the decisions will be made by the CCG? And the other quick question before I shut up, because I've taken up too much time, is we're at the moment advertising for a CEO. Is that a CEO of the whole ICS, or is it a CEO of the CCG effectively?
So it's a dual role. So it's the accountable officer for what is currently the clinical commissioning group and the integrated care system. So when that person comes into post in our current guise, then the accountable officer will obviously manage the CCG as it currently stands, and will also manage the developing integrated care system. So that's the role that it's there for.
So it's a bit like Jackie Pendleton, but with the ICS on top.
So it's probably a bit of actually, it's Helen's role at the moment, because obviously Helen is the accountable officer for the CCG, but obviously she's also the accountable officer for adult social care. She's got public health there, and then just add, as if she hasn't got enough to do, then she's got the integrated care system and its development and transition.
Okay, thank you.
Thank you. Rob, you wanted to come in for a quick question.
Yeah, yes, there's a couple of observations really. I mean, this committee and, you know, its predecessors have supported absolutely the closer working relationship between health and social care, no question about it. Personally, I prefer a white paper on the funding of adult social care. I think that's far more important, but I would say that, wouldn't I? I think the timing is shameful. I think the amount of energy that's needed to make this system work is immense. And we're on the tail end, hopefully, of a pandemic where everybody's been working flat out for, well, more than a year now. So I think the timing is pretty poor. I would like to think that as a local authority, we're going to have way more conversations about the implications of this paper than today, because I am certain, and I know, that our colleagues in the NHS have already had lots of conversations about what it might or might not mean, but we haven't. And to see it today on this, and it gives Caroline the chance to, we put questions in, and that's great. But we haven't adopted a position. We haven't got a view as a local authority on what it might or might not mean. So, and I know this is the last meeting of this committee, and time is not on our side, but I would make a huge plea that either there's a development opportunity for this committee in the next administration, that there is time set about, not just as an item on the general agenda, but the opportunity to have a real discussion about the implications to adult social care and the local authority, and to bring in, Helen Charlesworth-May and the Director of Adult Social Care that we've got, and ask them about what their take on it is. But let's not forget as well that the LGA have also produced lots of documentation about their interpretation of the white paper and where adult social care fits in it. And we need to be taking all that into consideration as well, because people have put a lot of time, energy and effort into those papers. And I don't think we've had the opportunity to take that into consideration as well. This is probably the next big step along the way of integrating health and social care. I welcome it. I think it's the right thing to do. But what I am concerned about is our ability as a local authority to put forward a view in support, to change it, to amend it, so that actually what we end up with is a system that's fit for Cornwall and the Isles of Scilly. And so it's, I'm excluding my NHS colleagues from this bit, but I think as a local authority, we really have to put time, effort and energy into what we think about it, so that we can come back with our NHS colleagues and batter those things out, so that ultimately we've got an agreed way forward in the view. And I think that's really critical. So I would say that potentially this is one of the most important items for the next Health Scrutiny Committee. Thanks.
Thank you, Rob. Yes, shall we go on to Nichols? Councillor Nichols, please.
Thank you. Well, I despair really, because we're going round in circles. We're reinventing wheels that we left in the 70s, and I just think we seem to be wasting time on bringing in trusts again. My concern is that the NHS are bringing in an accountable body, did you say? In which case, is that going to be medically led? And then the Health and Care Partnership Board will be underneath, but will be a bit of a toothless tiger. Because I know what the NHS do. I've been there at the Department of Health, and it just seems to me that there's no real strength in integration, because we've still got two bodies, a medical NHS one really, and the one that's health and social care. And I would like to see us actually feed back when we actually have, as Rod said, we really need serious discussions about this in terms of where we stand. But I'd like to see a really meaningful document sent back to NHS England telling them that actually we should be integrating properly and not just having 2 or 3 different boards. I just find it incredible that we still have got here. I mean, I remember at the Department of Health, there was the big meetings at Heathrow, I can't remember what they called it now because it was in the 80s, and that was about integration of health and social care then, and we still haven't really got any way further forward in terms of true integration. I just have concerns about actually who's going to be on the boards and how much it really is going to be true integration. Carolyn, I just, you know, I've been around long enough to be really cynical about all this.
That's absolutely fine, Councillor Nicholas. I don't think it will be hierarchical because it has been really clear that the health and the ICS, the integrated system, whoever is in it, have to be considered as equal partners, and that has been a message that we are certainly pushing, because there is no supremacy of one organisation over another. We are all equally as important to delivering a service or a care or whatever to our citizens in Cornwall and the Isles of Scilly. So my personal view is that it won't be hierarchical. It will be about equal partners. And just going back to Councillor Rochell's point about, you know, having a voice, that is absolutely the intention. So that we're just about to talk about setting up a steering group. I've just been working out council colleagues who I feel should be round that table. And then, you know, there is talk about what's going on at the boards at the moment, but it's only talk. We need to have conversations about who will sit in it, because you need to make sure there's equal representation, and you need to make sure that it's the right mixture of people who can make those decisions collectively together. I think your point about being clinically led, it's absolutely got to be clinical led, and it's absolutely got to have those place-based leaders as the voice, if you like, that we're listening to. So there's again a conversation at the moment about how do we bring clinical leadership from kind of the primacy of place. So, you know, those clinical directors, those clinical colleagues in adult social care, how do you bring them to actually start looking at how we shape it moving forward? Because that's where it's got to start. It's got to start there. They've got to have the voice in how we shape it. This isn't for, you know, people like myself or chief execs or whatever to make a decision about this is what we're going to do. Actually, it's been very clear that it's about primacy of place. So we need to be talking to place-based level colleagues to understand how do they think it's going to work around them.
I think that's the point, that we've got clinical lead directors, but have we got alongside them leads in social care?
Yeah, no, agree.
Okay, thank you.
You're welcome.
Thank you, Sue. Next on the list is Loveday. Councillor Jenkins, please.
Yeah, thanks. Sue's asked some of the things I was going to ask, but my key point, I suppose, is we're at the start of a process again. We've been at the start of the process for the last 5 years, and the process keeps changing as we go along, so that's not actually very helpful. I think there's been a lot of work in Cornwall to try and build a model that works together, and I would hate that to be lost in a new process. It slightly concerns me that the NHS England are going to mandate the makeup of the NHS body. Is that going to be flexible in relation to different areas and different perspectives, or is it going to be a standard model coming down from the centre? Similarly with Public Health England, you know, is that going to mandate how public health relates to it? And then whatever happens with social care, if that funding is taken away from local authorities and put into another agency, is that then going to mandate how that relates, which could mean that we end up with 3 silos mandating and preserving what they're doing rather than the integrated local system that we all aspire to. So how can we ensure that the local system that is place-based and actually relates to place and need, etc., for Cornwall and the Isles of Scilly is not undermined by what's decided centrally? I'm not sure that you have an answer to that, but I think some of what Rob said about Cornwall Council and the political perspectives needing to be brought into that is important, because we all know that Cornwall is a dispersed rural area that operates differently from some of the urban areas, and what fits an urban metropolitan area won't fit Cornwall. So we need to have something that fits Cornwall. So I'm not sure if you've got an answer to that, but that's the question in my mind.
Okay, thank you, Councillor Jenkins. I can't answer all of it. What I can say, though, is that there is a very strong voice that Cornwall and the Isles of Scilly retain its own status. There is regional kind of conversations about the ICE integrated care systems being bigger because of population sizes, etc. However, we are really clear that Cornwall and the Isles of Scilly need to retain its own integrated care system, not only because, as you rightly said, there's a lot of good work already been laid, the foundations have already been laid for this. I'm not sure we're quite at the start of another process. I do get what you're saying, as in the start of another process to moving to integrated care system, the term, but I think the view is of council colleagues that I work with and health colleagues and other partners is that actually for us this is just giving us some structure to build further on what we've already done and the good work that we've already put in place, and that colleagues are already working in this way. This is just almost kind of formalising some of those elements around them. So there's absolutely no intention to kind of lose any of that good stuff, and certainly a lot of the good stuff that's happened as a result of the pandemic. That it's been a very unfortunate year, but actually there has been some positives from our perspective come out of it, and we wouldn't want to lose that. But as I say, we're due about 4 or 5 extra pieces of information guidance, as they always call it, in the next kind of 4 to 5 weeks. So once we get to that will give us further information about how they're viewing it and what they think will be the bare bone framework, I suppose, of what they want us to deliver, or the bare minimum that we need to deliver. But they have been very clear on a lot of the conversations that I've had with the regional colleagues and NHSE colleagues, that the NHS body will be mandated, but the flexibility and the permissiveness of what we do around the integrated care system will be through the health and care partnership, and so that will be an important bit to get right.
Thank you. I think Rob's proposing something which I would totally endorse, which is about the structural arrangements for Cornwall and looking at how that's going to function. Needs to be something that this committee hopefully takes forward in the new council.
Okay. Thank you, Councillor Jenkins. Councillor Burr, Andy, over to you.
Yes, many thanks. Good afternoon, Chair. Firstly, I want to publicly thank our Chair for all his hard work over the past 4 years, and I was very grateful for his thanks at the start of the meeting, and also our officer who's worked so hard to get us papers that even arrive in the post on the day. I'm going to make a very brief observation that I think our committee should note that we did an extensive investigation and inquiry into the usefulness of integrating health and social care. It was a cross-party group. We worked very hard on it, and we came up with a ringing endorsement for this approach. We think it's the right approach for helping our residents, patients, clients across the county. And I hope, and it's great now to see central government catching up with Cornwall's great aspiration. And I hope this committee will welcome this bill from the government, and they'll get fully behind it and see all the benefits it can provide for joined up care for our residents in Cornwall. Thank you.
Thank you. Councillor Parsons, David, over to you.
Thanks, Armand, and thanks for all you've done over the last 4 years. I just want to make a couple of quick observations, really. I mean, you would be disappointed if I didn't mention cross-border issues, as I always do. We use beds in North Devon. I mean, I know South East Cornwall uses beds in in Derriford. There's also some stuff going the other way. We've got Devon now commissioning beds in Stratton Hospital. A third of the beds in Stratton Hospital commissioned by Devon. The 111 services are different on both sides of the border. The adult social care systems are different on both sides of the border. And I think, much as I would agree with Bert's aspirations to have a self-contained health and social care system in Cornwall, in practical terms, it's not going to happen very quickly, certainly. So we need to work with what we've got. And I would make a plea, really, that as we go into these discussions, we don't forget the complications and issues because the systems are different across a border. We've got 37,000 people, half on one side of the border and half on the other, and getting the 111 services and the community bed services and the adult social care services to work seamlessly for them is proving extraordinarily difficult at the moment. So please don't forget those cross-border issues. Thank you.
We won't. Thank you.
Thank you, David. Colin, Councillor Martin.
Thank you for that. I won't repeat what a lot of others have said, but the timing is curious. That we're told that that the whole system is too busy with its hands full with COVID to have an inquiry into what went wrong with COVID and how we should be better prepared for the next pandemic. And yet at the same time, we're told that it's got enough spare time to sit around drawing up plans for massive centralised restructuring. Andy Ver is absolutely right that we looked at the principle of this direction of travel back in our inquiry 3 years ago. But whilst we endorsed the direction of travel, we were very clear that we needed to look very carefully at each step along the way. And so it's good that a bit more information is coming out now about what the next steps might involve, but we're certainly not in a position to give a ringing endorsement from it. I mean, you've said yourself, this raises more questions than answers. So I'm concerned that this is our last meeting before a new council is constituted in a few weeks' time. I don't want anyone coming in on the new committee to think that we've rubber stamped and given a wholehearted endorsement to the white paper that's been put in front of us, because we just don't have the information to know whether we can approve it or not. Another thing that we touched on previously was when the joint role for the accountable officer for social care and the accountable officer for NHS Kerno was created, I very clearly remember asking the question, how will one person have the capacity to do something that two very hard-working, capable people were previously doing between two of them? And we were assured that the team was in place that had all the capacity it needed. And we got rid of, one very useful, capable person in Jackie Pendleton. Excuse me. But now we're being told that we need to recruit extra people, and I'm not clear now. I'm rapidly losing track of who does what job and how they all fit together, and that's a concern going forward. So I'm not sure what we do next. I think Councillor Kirkham's got a recommendation, and I'm inclined to go along with that, because basically all we can say now is we support the idea of integration. We applaud the work that has been done so far towards integration, but we need to tread very carefully going forward, especially when we don't know the future of funding for adult social care.
Okay, thank you, Colin. Councillor Chopak, Nikki, you were the last speaker.
Okay, sorry, to be fair, Colin and David probably touched on everything that I was going to sort of reflect on, if that's the right word. Obviously, I've been on this committee for 8 years, and it was it's almost like a deja vu. We've had conversations around changes and how we're going to integrate over many years. And I think I used the old adage before about, we seem to be shuffling the chairs on the Titanic, but nothing really changes. And I am concerned that, obviously, as Colin has touched on, that we're going, this is the last meeting this committee. This is a huge ask of any committee to take on board everything that's been discussed today. And my concern for the new committee in April, or whenever, May, this looks like we've rubber stamped something or looked at something in a bit of a whisper. So that was sort of partly my concern. Obviously, I also wanted to reflect on David's concerns around our cross-border issues, which he and I are obviously very passionate about. And I wanted to make sure that, yet again, that obviously that is carried forward through the new committee around cross-border working, which I didn't want that to be lost in translation. So it's not really a question, it's more of a statement. So thank you.
Okay, thank you, Nikki. Yes, I think Councillor Kirkham, did you have a recommendation? I haven't had a chance to look at it on the.
Kinda. I've tried to change it a little bit to make it make sense, but it's quite hard. I might need some help. It was this committee recommends number 1, the new Health and Adult Social Care Overview and Scrutiny Committee should hear evidence from all parties involved in the potential new integrated care system and produce a view on the new structural arrangements for Cornwall, including the Health and Care Partnership and NHS Cornwall, considering that it's very difficult to integrate 3 separately managed and funded organisations. And then I was going to put number 2, this committee believes strongly that any ICS should be for Cornwall alone, or words to that effect, so that we shouldn't be merging with Devon or Somerset or anything else. And then this white paper is, I was going to put half-baked, but that might be too emotive, and comes forth at completely the wrong time and claims to learn lessons from the pandemic before a pandemic inquiry has even been commissioned. So please feel free to add or amend that. Anybody else?
I think the first one is that we shouldn't just note this report. I think we should thank Mrs. Andrews for her presentation and the overview of the ICS, and then maybe the second and third thing. Are there any councillors that wish to add to this debate at this time? Especially when my second computer has just gone off.
Yes, Chairman, if I may. Ms. Biscoe.
Okay.
Well, I don't want to say I have to leave very quickly, so I don't want to say it because I'd like to get on with the vote. I very much support that this should be a key item for the next committee. I think that's absolutely right. I very much agree with pretty much what everybody has said. I understand what David and Jackie are saying about cross-border issues. I think the problem is that we are looking at a proposal which includes accountability and includes integration between 2 services on a place-based basis, with clearly, Cornwall being the place that we would want to see this happen. At the moment, we have not got a health service which provides to all the people in Cornwall. It's actually the issue as far as Derriford is concerned. This is that people east of St Austell, which is nigh on half the landmass of Cornwall, as well as the people in North Cornwall who go to Barnstaple. These are significant chunks of our population. And in terms of the governance, in terms of equality of access and so on, in terms of accountability, there's some really interesting. What I've been thinking about throughout this discussion really is I pity the poor chief executive of Derriford, because he's going to be dragged in 2 competing directions in order to try, if we go on in the way we're going, and I think that will become an impossible job for somebody to do, and it'll be a hospital and an area of competence which is caught between 2 very different stools. and that will have an effect on quality, on morale, and on efficiency. So I do think there are some very big questions to look at. Some of them are structural, some of them are locational, some of them are how we actually do things. And I would temper David's description of my aspirations. I have as many fears as I have aspirations, one of which Jane Kirkham was just touched on by saying that we don't wish to be seeing ourselves integrated with other places, and quite rightly. Our geography is that we're essentially peripheral, and the government needs to take that into account when it helps us, and we work with them to design what we do. I fully support the integration of care and health, but I think we're going to have to find a bespoke Cornish and Solonian model in order to be able to do it properly. And therefore, I think it's not just a matter of this committee looking at it in future, but indeed the whole council, because I think there are implications for everybody. This is the biggest ticket item on the public budget, if you put the two things together. And in those terms, it will affect the way in which future governance, future constitutional referendums are made. And I think we need to take that into account. Huge implications for us.
Okay, thank you, Bart. Councillor Burr.
Chairman, could I just interject
Yes, of course you
quickly? Apologies, Councillor Burr. Just to highlight the time to members that we have to change the live stream over at 2 p.m. So we can carry this conversation on post 2 p.m, but we will need to stop the discussion in a couple of minutes so that the live stream can be changed over by the live stream operator, which means the public can continue to watch.
Yes, Councillor Barrett, do you want to come in?
Yeah, many thanks. We are in danger of repeating the error of our last committee meeting, where we forgot that we are supposed to be a non-party political committee, where we are supposed to reflect and hear the evidence that we've received and make judgments that are helpful for the council and the wider health community. So I don't think I can support the last point of Councillor Kirkham's recommendations around the timing. I think that we may have our own personal view on that. We may have our own personal political view on that, but I don't think this committee has heard any evidence from the leaders of our organisations as to whether or not they feel they have the time or the capacity, or whether they felt personally this was the right time to be entering into this development. I think that is a purely personal / political view, and I don't think it's beholden on this committee to include that in its recommendations. Thank you.
Thank you, Councillor Burr. Councillor Jenkins.
Chairman, I would suggest that we stop so we can change the live stream over. If I can speak to the live, just because we're going to run out of time. Councillor Jenkins, would you be able to hold your question for a matter of minutes whilst we change over the live stream? Is that okay?
Yeah.
Fantastic. Sorry, Chairman, I just don't want the conversation to be lost for the public.
Okay, thank you, Deanne.
Everyone stay here. You can just mute. That would be fine. Everyone in this meeting stays the same, but we just need to turn over the live stream on the other piece of technology.